Guys, welcome back. The agenda today is to hit the nail on the head, and I'll be covering the topic of dyselectrolytemia. I'll begin by first teaching you regarding the correction formulas which are to be used for any patient who's having dangerous hyponatremia or hypernatremia. The normal sodium in the body would be between 135 to 145, any value less than 125 and any value more than 158 millicolents can cause fluid shifts across the brain and can explain the development of seizures. Now this question said a 60 kg female. In these questions of electrolyte imbalance, gender is always important because you need to calculate the total body water. Whenever you're gonna consider a female patient, what you need to simply do is multiply the weight of the patient by 0.5, and if it's gonna be a male patient, then the weight of the patient should be multiplied by 0.6. The question describes a lady who's sick for past 1 week and is admitted with seizures, and the workup showed the sodium values to be dramatically low. The potassium values were given to be normal, 3.5 to 5.5. This is 4, so that's perfectly okay. And then there is also a mention of deficit of chloride. Normal chloride values, they can vary between 96 to 106 millicolats. And here the plausible explanation why it can be lesser is that this sick patient might have had vomiting episodes. Though the vomiting is not described in the question, but that's a plausible explanation. And the question said calculate the correction to be done in the patient in the next 24 hours. So what you need to do in this question is first and foremost evaluate the total body water, which I've already done for you, weight multiplied by 0.5, and the subsequent formula is the one which is the tricky part, that you need to multiply this by the difference of the desired value minus the actual value. Now the actual value which is given in this question is 120, but what do I desire? Now here the important thing is that if I want to calculate the total correction to be given to this patient, the word is if I want to go in for total correction in this patient, then I would like to increase the value of sodium in the body of this patient to 140, which is an average between 135 to 145. And if I multiply this would be 13 to 20, that would be 600 millicolents is the correction which is required to be given to these patients. But the point is, in this MCQ, the trick was that he did not ask for the total correction. The question rather asked what will be the correction that would be done in these patients in the next 24 hours. The point or the logic is that whenever there is a dangerous hyponatremia occurring in a patient, we do not try to correct to normal values within 24 hours. I would like to give it time, maybe 48 hours, maybe 72 hours. It's a gradual rise that is recommended. And in 24-hour period, we usually like to upgrade the value by at least 8 millicolents in the blood. Like suppose in this particular question, the admission value was 120. Then my objective is that in the next 24 hours, I can upgrade to 128. So the desired value will change. Now all you need to do is multiply 30 by the difference of 128 minus 120, that would be 8. And if I just do some basic mathematics here, this would work out to 240 millicolents. So in this particular question, I would like to reiterate the statement that whenever he is asking you for correction of hyponatremia, always have a look at the fact that whether is he asking you the total correction to be done, or instead of the total correction part, is he asking you regarding how much is the correction which is to be given to the patient in 24 hours. In the topmost part of the formula, I've written formula for calculation of total sodium deficit, whereas inferiorly you can see I've written sodium deficit to be corrected in 24 hours. The correct answer for this particular question, approximate value is 240 actually, but the closest answer would be option number B. And had this question not mentioned this next 24 hours, then the answer for this question would have been option number D. So you will find some differences in recall. I mean, I can call this question as a recall bias as well, because when I spoke to my students who had given this exam in which this electrolyte imbalance hyponatremia correction was asked, some said, sir, I remember that it was total correction that was asked. Some said, sir, it was over 24 hours. So anyway, the point is I've handled both the versions here. If it is total, then it is desired value would be taken as 140. Now, once we get this mathematical formula right, I would also like to say that every time you are doing this calculation based MCQs in the exam, it has to be either a one-step multiplication or one-step division. I mean, if we are using some rocket science kind of a formula, that basically means that the question is going wrong. Like in this question, I'll just go back and you can see it was almost a one-step multiplication which had to be done. And the critical point was to calculate the total body water based on the gender of the patient. You can remember like this, when it comes to male patients, though I've said it verbally, I'll just do that activity again. In a male patient, the multiplication factor to be used is 0.6. And in female patient, it's going to be used as a multiplication factor of 0.5. Now, when it comes to the topic of hyponatremia, most of the time they'll be using terms like hypovolemic or euvolemic or hypervolemic. So I'll explain these terms to you. Now, if a person is having less of total body water as well as TBS, means total body salt is also less. So the words that are used to describe this would be hypovolemic hyponatremia. But if you look at the second entry, you will notice that total body water is more and total body salt is normal. Because total body water is more, the usual impression is we are going to call it a hypervolemia, but that is not the case. In fact, if total body water is more, then it will cause dilution effect to come in and will explain the hyponatremia component. This particular description that I'm giving before you will be for euvolemic hyponatremia. The meaning of the word euvolemic is that water in the body is more. You can take a simple example for it, that is SIADH. Excess of antidiuretic hormone will draw more water, it will cause dilution, and that dilutional hyponatremia would be technically written as euvolemic hyponatremia. The question then arises, when will we say hypervolemic? For hypervolemic, you need to remember that both of these things should be increased. That is, total body water should also be more and total body salt should also be more. You can also see that I put two arrows in front of total body water and single arrow in front of total body salt to say the mathematics coming up, that because water is more as compared to salt, the dilution component is valid here also. But because both are increased, therefore the technical term that you will describe for this would be hypervolemic hyponatremia. And one of the important reasons why this could be happening is due to increase of aldosterone, whether it's going to be heart failure or ascites patient. If aldosterone is more, there will be more salt as well as more water in the body. This more water in the body also contributes to edema component that we commonly see with patients of congestive heart failure. Now, once we understand the definitions here, the hypovolemia component is one of the easiest ones to understand. I'll be jotting down some important causes that you should be knowing for each one of these. As far as diarrhea and vomiting are concerned, nobody will ever mess up on them. This is simple volume depletion that explains hypovolemic hyponatremia. But the important one from the exam perspective is what I'm writing right now before you, that is cerebral salt wasting syndrome. Cerebral salt wasting syndrome as a term is what I've said even in the topic of subarachnoid hemorrhage. These patients would be having a release of BNP, B-type natriuretic peptide, and this B-type natriuretic peptide would cause salt loss via the kidney, and therefore there would be a decrease of water as well as to salt, because along with salt, water will also be lost from the body. Cerebral salt wasting syndrome is seen with conditions like subarachnoid hemorrhage, which may or may not be given in the question, but CSWS anyway gives a hint to the diagnosis of hypovolemic hyponatremia. And then is another condition where you always read about salt wasting, because if aldosterone is less, salt will not be absorbed, and along with salt, even water will be lost. Now, before we go into what is the treatment that would be done in this particular case, let's focus on the most important of these. I mean, most of the questions in your exam, including the FMG exam, would be asking you regarding euvolemic hyponatremia. So do not neglect this topic, euvolemic hyponatremia, coming up. In the first entry that I would like you to remember here is SIADH, syndrome of inappropriate ADH secretion. Now, there is a possibility that they may not write the word SIADH, but they might write causes of it. Two must-know causes that you will always notice would be asked is, one I've seen is a hot favorite of FMG, one I've seen is a hot favorite of the NEET PG. In lot of previous year FMG exams, he has talked about a AIDS positive patient with a CNS infection causing seizures. In fact, I would like you to read up the AIDS topic from the main videos as well for the opportunistic infections part. There, I mean, it's the infection part is pretty concise, so it can be covered in a shorter duration. And any AIDS patient having seizures, cerebral toxoplasmosis should be kept in mind. In this patient, cerebral toxoplasmosis, because there would be triggering of SIADH, there would be excess of water, and this excess of water will cause then a hyponatremia component, which can be dangerous enough to cause development of seizures. So see the linkage that the examiner is expecting from you, that there's a CNS infection causing a SIADH and then subsequently electrolyte imbalance. And then the second hot favorite is what you always read even in NEET PG exam. They love to ask about lung cancer. The aggressive one, small cell cancer / root cell cancer, can be having a paraneoplastic manifestation of SIADH. In fact, this is the commonest paraneoplastic. I mean, paraneoplastic means both hormone production and antibody production. If he talks about the commonest hormone which is overproduced with respect to root cell cancer of the lung, then it's going to be antidiuretic hormone. The next reason for this could be post-operative. Now, the query for most people is, sir, if a patient is post-operative, there would be nausea, vomiting. So, would that not contribute to hypovolemic hyponatremia? Yes. Post-operatively, patients can develop hyponatremia and even a hypovolemia as well, but we prevent this from happening. Like, suppose a patient is post-operative, then what can happen is that the doctor might actually go in for a non-judicious use of IV fluids. We always give maintenance fluids. We might actually give too much of them. So if you're giving, the plus here means that IV fluids were given to a post-operative patient because obviously you can't take early. The doctor was over enthusiastic and he gave a overcorrection, I would say, or I would say excess amount of what was required. And if you give more of IV fluids, there's a lot of water in them, so that can explain the euvolemic hyponatremia which is present in the patient. So do not take, when I write the word post-operative, as that the patient is having nausea, vomiting. It is rather the doctor did a overcorrection or gave too much or a aggressive use of IV fluids is the reason behind it. Then another scenario can be a marathon runner. And this marathon runner, when he or she is running, he will be sweating profusely. So there would be loss of salt from the body as well as water from the body. And what this endurance sports individual is doing is that on the way, when he's nearing the finish line, he's also drinking water also. You see, lots of time you see when these athletes are running marathon, there would be some stalls on the road where they can pick up a bottle and they can drink energy drinks, which would be having electrolytes as well as waters. Ideally, it is electrolyte rich solutions which should be taken in these patients because they are losing salt also and water also. So replenishment will occur. But there is a possibility that this guy drank too much of water. If you drink too much of water, salt is getting lost from the body. But if he's trying to drink too much of water, instead of dehydration now, what will happen is that there would be a large amount of water going in the body. It would be absorbed also because after all, there is a dehydration component. And therefore, in endurance sports, it's important that the coach or the sports medicine doctor who's attached to this individual must ensure that this guy is taking electrolyte rich solutions. The next one is the most surprising of the 4 entries that I'm doing, that is hypothyroidism. I mean, the first time you read it, you say, I mean, what's the link? I mean, thyroid and related to seizures or hypothyroidism resulting in electrolyte imbalance. I mean, we read about cortisol or aldosterone contributing to electrolyte changes, but thyroid hormones contributing to electrolyte imbalance. How? Then thyroid hormones produce a check on the release of antidiuretic hormone in our body. The routine function of thyroid hormones is going to be like calorie genesis, heat production in the body, basal metabolic rate. But the thyroid hormones also play indirect role in regulation of release of antidiuretic hormone. Now, in case there is going to be deficiency of the thyroid hormone, this check is gone. And if the check is gone, antidiuretic hormone production will be more. The endogenous production will be more, and more antidiuretic hormone means that there would be more water in the body. A common thing that you will notice in most of the entries that are made in the middle of the table, which I would rate as the most important table for hyponatremia, is the one that I highlighted at the moment. The middle part, the causes of euvolemic hyponatremia, are the ones which are usually asked in the exam. As far as the extreme right hand side of this discussion is concerned, that would be hypervolemic. Then one of the causes that can be remembered is congestive heart failure. I mean, every time there is CHF, there would be less blood supply to the kidney, and that will cause a positive stimulus to the RAS system. And if the RAS works over time, then there would be more aldosterone in the body. Then another example for this would be cirrhosis, which can not only cause ascites, but at the same time in these patients, I mean, why do we advise salt restricted diet in these patients is because you can see that water in the body is anyway more, the salt in the body is also more thanks to aldosterone. Then any patient having chronic kidney disease. Now the causes for CKD, he can write like diabetic nephropathy, polycystic kidney disease, no problems with that. But the point is, every time there is CKD, the RAS system goes into overdrive and there is an increase in aldosterone. In the middle of the table, the main problem was antidiuretic hormone. On the right hand side, the problem is with respect to hyperaldosteronism. And once we get the causes right for these, because all except questions can be asked, my next objective would be to mention regarding the treatments that would be given to these patients. Now in Addison disease, obviously, the way I put an arrow, that does not mean that I'll be treating Addison disease with ORS or I'll be treating Addison disease with IV fluids. Rather, I'll be giving hormone replenishment in the patient. Any patient with Addison disease, we can be using hydrocortisone, and because it has a mineralocorticoid activity, also in a glucocorticoid activity, so you will have is a stabilization of the sodium values in the patient. But I have written ORS and IV fluid mainly to counterbalance the electrolyte and the water loss that occurs with the first three causes, that is diarrhea, vomiting, is cerebral salt wasting syndrome. So that's one of the broad treatments that we do in these patients. Though specifically if he says Addison, then I'll go in for hydrocortisone. Let's focus on the middle of the table now. In any patient having euvolemic hyponatremia, what would you do? So you would go in for fluid restriction. Look at the dramatic shift in the approach that I am talking about. Any patient having hypovolemic hyponatremia, I'm giving ORS, I'm giving fluids from outside. If I don't have access to ORS, at least I'll try to correct the water deficit in the patient. But in this case, because water in the body is already more, so we'll be going in for fluid restriction. And for SIADH specifically, we would also like to use drugs which are gonna neutralize the overactivity or the excess amount of hormone which is causing overactivity of the V2 receptor. So to block V2 receptor, we will be using tolvaptan in the patient, so Vaptans would be used. Whereas if you come to the extreme right hand side, any patient of heart failure, if he's having a hypervolemic hyponatremia, I will be giving diuretics. Now the choice of diuretics will change, because like in heart failure, we use furosemide, in acute heart failure, thiazides in chronic, but if it's cirrhosis with ascites, we use spironolactone, which is a potassium sparing diuretic. But the point is, if I have to neutralize this, then diuretics have to be used to neutralize the increased amount of aldosterone on the extreme right hand side. So whenever he talks about treatment for hyponatremia, your role will be to check out, is he giving you a cause for hypovolemic hyponatremia? Is he giving you a cause of euvolemic, or is he giving you a cause of hypervolemic? Because the answer to each one of these will vary. Now, dangerous hyponatremia is any value less than 125. And in the question that I mentioned before you, it was given to be 120. And since I've come to this slide again, I want to reiterate my statement. Always read the question whether he's talking about a total correction or the correction to be done in the patient in the next 24 hours, because every time we do a fast correction, there is a problem. The fast correction, like suppose a patient came and his sodium values are 120, and within, let me say, 12 hours only, forget about 24 hours, I'm giving fast administration of fluid. I have hypertonic saline at my disposal also. So the fast correction of any patient who's having a hyponatremia can be a disastrous situation, which can cause the person to land up in a stroke-like situation. And the condition that will develop is called as central pontine myelinosis. Now you will notice that in the current edition of the textbook, that word central pontine myelinosis has been replaced by an alterated term, that is osmotic, because there's fluid shifts across the brain, osmotic demyelination syndrome. I said the manifestations that can occur in this patient can be stroke-like. It could be quadriplegia developing, mutism developing, aphasia developing in the patient. Stroke-like features are usually encountered. So therefore, we should not try a fast rise. We should try a gradual rise in the patient. If he says, what is the best way to correct dangerous hyponatremia? What fluid will be given for dangerous, like somebody is having seizure? He says, what fluid would be given? In the exam, he just asks you correction. But if he says a patient is having dangerous hyponatremia and at the same time is having cerebral edema, which contributes to seizures, the fluid of choice in these circumstances would be given as 3% saline. For routine vomiting, I can be giving normal saline to the patient. If it is a cholera patient, I can be giving ringer lactate to the patient. So I will correct the electrolytes, I'll correct the water deficit in the body of the patient. But if he specifies fluid of choice For dangerous hyponatremia correction, what would be recommended? It is 3% saline. And they've also asked a value-based question that how much sodium is present in 3% saline. In the routine, 0.9% saline, 0.9 because it is isotonic with respect to RBCs. The sodium which is present is 154 milliequivalents per liter. Minded, it is not per 500 ml. One bottle would be 500 ml, 540 actually. But the point is that this is not per bottle, it is per liter. Now for the 3% saline part, all you need to do is just mix up these numbers 1 and 5. You just need to invert them, write 5 first and then 1, that would be 540. Number 4 would remain the same, just shift the position of 1 and 5 and you would get the sodium present in 3% saline, which is the preferred fluid. The first time if I ever spoke about hypertonic saline was in central nervous system. If a patient is having raised ICP, I can be using mannitol or I can be using 3% saline. And today I've told you that this would also be useful for correction of dangerous hyponatremia in the patient. Now let's look at the opposite aspect of it. When would you say that the patient is suffering from dangerous hypernatremia? Then values more than 150, it can again cause fluid shifts across the brain and development of seizures. So he can ask you which is the correction fluid that should be given to this patient so that you can bring the sodium values back to normal. And I cannot allow water intake in this patient, liberal water intake, because he's having seizures. I mean, if person is asymptomatic, you can allow water intake. But if the guy is having seizures, you need to give a fluid. So if he says what is the fluid to be used in the patient, your answer would be given as 5% dextrose. Two very simple straightforward questions, especially in the FMG exam. They said correction of dangerous hyponatremia, hypertonic saline 3%, and if he says for dangerous hypernatremia, then answer is 5% dextrose. This would be sugar in water, no, so you need to give water to the patient, and once the water will be given, then the sodium values will start coming back to normal. And even here I would like to go for a slow correction. Like suppose the admission value is 160 and he's having seizure, so I will not decrease from 160 to 140 in 24 hours. Again, there would be a osmotic demyelination like a presentation. So what I need to do is downgrade by again 8 milliequivalents. The recommended guidelines are do a slow correction for both hypo and hypernatremia. That is like, we normally in hospitals, we always nowadays calculate bed turnaround time. I mean, especially in corporate setup, they are always interested in more revenue being generated per bed. The more the bed is recycled from patient to patient, more revenue is what you earn. But in this particular case, if you try to be fast, then it can be counterproductive. Now, what is the leading cause of why a person would be having a hypernatremia? Like in hyponatremia, there were so many causes, but for hypernatremia, he's saying what is the leading cause why a person can be having a situation like this? Then it would be a debility in old age. Like let me say he's a case of Alzheimer's disease or Parkinson. If a Parkinson disease patient is a wheelchair-bound patient and he cannot get up from the bed by himself in a hot Indian summer when temperature is 48 degrees Celsius and that heat wave situation is going on, we don't expect that person to get up from the bed by himself, go to the refrigerator, open the refrigerator, take out a bottle, open the cap, pour the water into a glass. I mean, Parkinsonism patients have bradykinesia and even akinesia. They're dependent on others for routine simple tasks. So debility in old age is one of the important reasons. And let me say this old man fell in the bathroom and he had a fracture of the neck of the femur, for which he also underwent a joint replacement, a hip joint replacement. So I am saying double insult. A known case of Parkinson disease having a hip joint replacement surgery, or Alzheimer's disease patient having undergone a joint replacement surgery. So the physical disability of the patient will prevent him from getting water. And if he does not drink water, the sodium values will keep on rising in the patient, which will result in agitation or I would say even in subsequent cases, altered mentation in the case as well. Now we will talk about what are the important causes for development of hypernatremia. Though I told you the leading cause happens to be disability in a patient, they can ask you about medications which can be causing it. And one of the medications which is causing it is lithium. Now you're all aware of the fact that lithium can contribute to development of nephrogenic diabetes insipidus. And if a person is having nephrogenic diabetes insipidus means loss of water from the body. If the person will keep on losing water from the body, if you have tremendous loss of water from the body, which is not being compensated by drinking adequate amount of water due to the debility component that I mentioned, then loss of water from the body will cause the sodium values to increase. So though diabetes insipidus is what I have written 2 times in this discussion, both central diabetes insipidus and nephrogenic diabetes insipidus. You all know that the treatment of choice for nephrogenic diabetes insipidus is thiazides because they affect the polyuria component by affecting polydipsia. You see how thiazides work in nephrogenic diabetes insipidus is again a enigma, will look like an enigma to you initially, no, because diabetes insipidus there is polyuria and thiazide is a diuretic. I mean, if you tell a person who's having diabetes insipidus and is having a polyuria that I will give a diuretic to you, and when he Googles about it, diuretics cause a further increase in urine output, the patient will come back to you and say, sir, I am fed up of going to the washroom again and again. He's already having a polyuria and now you're giving diuretic to this person. The logic is that thiazides will also act on the UVLT, the osmoreceptor, and they will reduce the stimulus for water drinking. And if you decrease the stimulus for drinking water, if the intake is less, then the urine output will also decrease. So one, you should be aware that nephrogenic diabetes insipidus is treated by thiazide diuretics. How? Because it affects the thirst component in the patient. And then you need to remember, one of the drugs causing nephrogenic diabetes insipidus is lithium. Another drug that I can mention, though I don't think so that would be asked in the question, is steroids. Or he can talk about a bodybuilder who's taking anabolic steroids. Even excess of anabolic steroid injections in, like, let me say, bodybuilders, weightlifters can contribute to dangerous hypernatremia coming up. Then can be osmotic diuresis. If you're giving a large amount of mannitol, like a patient had a CNS event, maybe let me say case of tubercular meningitis, and he started having a bit of posturing. So you thought that I should give him mannitol. When you give too much of mannitol, then again the loss of water in the body can be disproportionately high and therefore the sodium values can rise. Similarly, if there is excessive water loss, just to complete the mnemonic, and low water intake, the debility component that I have already explained to you, it could be a description of a Parkinson disease PD or AD patient with maybe a joint implant surgery done recently, which could have resulted in post-operative status of this patient. I'm not saying immediate in the recovery unit, maybe 1 week after surgery, this guy could land up in a dangerous hypernatremia situation. Now, what would be the clinical manifestations of patients of hypernatremia? Then one cause of hypernatremia from pediatrics that I would like to mention is incompletely, or I would say improperly prepared ORS. ORS should always be mixed with 1 liter of water and given to the patient. Now, because ORS tastes very horrible, lots of time you will see that, if you ever drunk ORS in your life, you know how tasteless it is. It's horrible to drink, and therefore some children, when they drink it, they puke. So the mother thinks that the taste is not good because it is tasteless, and she will put more of powder. If you put more of powder to sweeten it, then it will not only osmotic diarrhea component. I mean, ORS would contribute mainly osmotic diarrhea. The point is that improperly prepared ORS is one of the main reasons why in pediatric age group, in a patient of diarrhea, you could rather be having a hypernatremia because water loss is occurring. Already there was loose motions and now you are causing osmotic diarrhea component occurring. So therefore the sodium values in the patient will begin to rise. This also explains that why WHO discontinued the standard WHO ORS. I would say like this, when you were kids, you would read or you would see advertisements or you would hear on FM radio the advertisement saying WHO recommended ORS to be given to all children with diarrhea. But now they are telling that it should be low osmolality ORS. That would be 245 milliosmoles. That is why, because the initial WHO ORS was 311 milliosmoles. And the problem with this WHO ORS was because it was concentrated even more than that of the plasma. If the mother is not going to dilute it properly, then when you give it to the patient, it will cause an osmotic diarrhea component and will cause a rather hypernatremia developing in the patient. And the examination finding of this patient in pediatric books would be described as dewy skin. Now, this may or may not be present in adult patients. So you will have features of salt in hypernatremia. The skin would be flushed. There would be agitation on the part of the patient, low-grade fever, and the thirst of this patient would also be increased, and he may not have access to water because of the disability component due to the reasons that I have explained to you. Now, let us give you a situation. The situation is that he in the exam is telling you that the person having hypernatremia is asymptomatic. Like, for example, post-operative case, maybe 3rd day, 4th day, you found that the sodium report of a patient is 150, or let me say the nurse, while she was entering the sodium values in the computer or in the file, she said, sir, this sodium value is elevated. So she just showed you the report and she said, sir, is there anything to worry? The patient was complaining of headache. So I will tell her that yes, you need to tell the patient to drink as much water as possible. If you are listening carefully, you will have noticed that in SIADH, I was talking about fluid restriction because already there was more water in the body. But now I'm talking about liberal water intake in asymptomatic hypernatremia. Then one of the important investigations that must be done in these patients is obviously electrolytes, but along with that, urine osmolality also plays an important role because you would be checking out whether the values are in the range that I have mentioned before you, less than 250 or more than 400. This helps, this makes your life easier because if you are having osmolarities which are very low, that means that antidiuretic hormone is either not there or is not working due to nephrogenic diabetes insipidus, due to the V2 receptor failing to respond to the effect of antidiuretic hormone. So diabetes insipidus would be possibly present, and then subsequently you obviously need to do a water deprivation test to confirm it. In contrast, if you find that it is more than 400 milliosmoles, then either it could be osmotic diarrhea or it could be even osmotic diuresis due to excessive use of mannitol, which I said lots of time can happen in the ward as well. Now, what is the formula for correction in a symptomatic patient? The formula would be total body water. Every time there is an electrolyte imbalance with respect to sodium, you are supposed to calculate the total body water in the patient, and then you need to remember desired value, whichever is the actual value which is to be put first, and then is the desired value. The desired value in the patient is 140. I am going in for total correction in this patient. I said ideally we should correct slowly. So in this particular case, instead of putting 140, if I am talking about 24-hour period, then I don't want a value. The admission value of the patient is 160. I will downgrade by how much? I will downgrade by 8 points. Downgrade by 8 points means 152. So this mathematical value that I'm marking before you, if it is for 24 hours, this value will not be 140. It will be 152. You have to upgrade in dangerous hyponatremia by 8 millicoulomb for every 24 hours. If it's elevated, you need to downgrade by 8 millicoulomb. But if the question simply says, because for ease of calculation, most of the time they will ask you total. If he says total per se, for total, that then the value that I need to keep is 140. I mean, that's the desired value. The actual given is 160. And if we go into the mathematics here, the amount of fluid required in the patient would be approximately 4 liter. And I'll not administer the entire 4 liter in a 24-hour period. I'll be relatively slower, maybe give 60 to 70% of this in the first 24 hours and recheck the sodium values in the patient. And lots of time you will notice a faster recovery also. All of these patients should be ideally kept in intensive care unit for a duration of at least 48 hours before you decide to shift them to the ward. Both cases of dangerous hypo and hypernatremia deserve the required care that I'm talking about. We shall now be talking regarding a patient who's having hypokalemia. Now, the ECG findings of hypokalemia have already been discussed in the cardiovascular section. So for the ECG hand-drawn images, where I've shown regarding specific findings like ST depression and T-wave inversion, you need to refer to the cardiovascular section part. Here I will use this opportunity to talk about some other aspects of hypokalemia that have not been talked about in the previous videos. All patients of hypokalemia will have muscle cramps. If you've ever had diarrhea in your life, a nasty episode of diarrhea, then after a few loose motions, once the sodium values begin to fall from 3.5 to 3.3, 3.2, 3.1, we all would have undergone weakness, or we would have experienced weakness and muscle cramps. But if the values continue to fall and drop less than 3 millicoulomb, they could be a paralytic ileus, and they could even be flaccid paralysis. So whenever we have a patient in whom we are suspecting Guillain-Barré syndrome, I mean any patient with flaccid paralysis, any patient with quadriplegia coming in your hospital, or let me say paraplegia coming to your hospital, you must always get electrolytes done. Before you say it's a neurological reason, electrolyte imbalance should be ruled out in all patients presenting with paraplegia or quadriplegia. Now, if a person is having hypokalemia, you need to give potassium correction. It could be pot chlor. Lots of time in your wards, you would have seen that congestive heart failure patients, when they're put on diuretics, then excessive use of diuretics like furosemide can contribute to hypokalemia. And what will the physician do? He will give pot chlor. Pot chlor is a solution which we mix with water and we make them drink it. And pot chlor is recommended if the potassium values are between 3 to 3.5 millicoulombs. So if it is less than 3, then we require a IV correction. But if the values are between 3 to 3.5, it is the oral correction which is to be done. And in our case, the potassium correction was given. If it was less than 3, IV correction was given. If it is between 3 to 3.5, oral correction was given. But still the weakness of the patient is persisting. And the question said, which electrolyte imbalance could be present in this patient? And guys, this that I'm discussing before you is shockingly a FMG exam question. He said a patient has presented with hypokalemia. The doctor has given correction for hypokalemia. But in spite of giving correction, listen to the words carefully, in spite of giving correction, the weakness in the patient is persisting. He says, what could be the reason? So I give you a few seconds. I think I've explained myself pretty well. I said, what could be the reason behind a chap in whom correction for hyponatremia has been given? He had a hyponatremia correction given, still weakness is persisting, and the potassium values have come back to normal. Let me say if the potassium value was 3.2, you are given a correction, so it has come back to 3.6, 3.8, still the weakness is there. So what electrolyte deficit could be present in this patient concomitantly? The answer of yours would be hypomagnesemia. Lots of time we might be having features of hypomagnesemia. I'll be covering hypomagnesemia in my subsequent slide. The findings of hypomagnesemia may be actually masked by the findings of hypokalemia. I repeat the statement once again. You had a patient who came to you with weakness. Maybe potassium was lesser. You gave correction. Potassium value came back to normal. Weakness is still persisting. What electrolyte imbalance must be suspected in this guy? Then your answer is hypomagnesemia. Then the main reason why patients of hypokalemia can die is because of muscle paralysis. Like in hyperkalemia, if potassium is more than 8 milliequivalents, patient can die because of diastolic arrest of the heart. In hypokalemia, the cause of death would be muscle paralysis, that is diaphragmatic paralysis. If it's not a diaphragmatic paralysis, there could even be arrhythmias. One of the arrhythmias that I've described in the cardiovascular system is Torsades de Pointes. Important question to be remembered, that hypokalemia, in fact both hypokalemia and hypomagnesemia can trigger Torsades de Pointes in a patient. Then there's a special test that is called as TTKG, that is transtubular potassium gradient. This TTKG is one of the reasons why I have decided to talk about this question or this topic per se. Otherwise, I've talked about hypokalemia even in the cardiovascular section. Then hypokalemia, transtubular potassium gradient. There's a formula for it. You don't need to remember the formula. I just wanted to remember the values more than 4. It indicates renal wasting. Two important causes of renal wasting that are always asked are Gitelman syndrome, where the problem would be in the distal convoluted tubule of the patient, or it could be in the thick ascending limb of loop of Henle, that could be Bartter syndrome. The defects are DCT, and in Bartter syndrome, it would be the thick ascending limb of loop of Henle, and both of these conditions would be having a potassium-based wasting or kidney-based wasting occurring. Then the ECG finding in these patients would be that of pseudo P pulmonale. We very well know that P pulmonale is P wave more than 2.5 millimeter in presence of pulmonary artery hypertension. Here there is no pulmonary artery hypertension, still we are having a P wave amplitude increase, so we call it pseudo P pulmonale. Whenever potassium goes down, ST also goes down, T also goes down, so there is a T wave inversion. TWI here means a T wave inversion occurring in the patient. Along with that, ST would also go down. Let me just utilize a few seconds to say what's happening. This is normal, and then in a chap with hypokalemia, you will notice the following problem. The P wave is increased in height. Then there would be a significant ST depression with a T wave inversion, and sometimes a new wave would come up. And this new wave that I've shown before you is the U wave. So you will read questions saying prominent U waves. Along with T wave inversion, you can see a positive reflection. That's a prominent U wave that would be developing in these patients. And therefore, in the exam, because he knows that prominent U waves you will answer, so he might ask you regarding QU interval. QU, normally we study QT interval, no? Normally we study QT interval, but in this case, the T wave is inverted and there's a new positive wave coming up. So it's QU interval prolongation, which is itself a question and should be remembered for hypokalemia. All the words that I've said here for the ECG findings, though, I mean, I tried my best not to speak them, but these are so frequently discussed in the exam that even in cardiovascular system and right now, I literally could not stop myself from talking about them. When it comes to a patient having hyponatremia and the values are less than 3, like let me say the values are down to 2.5 or even lesser than that, I need to give a correction. Now the formula for correction that you need to remember is, now what I want here is that if I want sodium to rise by 1 milliequivalent, like suppose it is 2.1, if I want to increase to 3.1, that is a rise of 1, then I need to give 200 milliequivalents to the patient. Basic elementary mathematics. I'll repeat that again. Suppose patient is admitted with a dangerous hyponatremia, values 2 milliequivalent. If I want to upgrade from 2 to 3, I will have to give 200 milliequivalents of KCl, potassium chloride, and potassium chloride should never be given directly. It should be always added to the IV fluids and should go in the form of a drip. The question in the exam said, a patient on amphotericin B, you know this drug contributes to hypokalemia. The patient developed muscle cramps and the potassium values on admission were 2.3. The question said, calculate the correction to be given to the patient. In this particular case, what I need to do is I need to upgrade from 2.3 to 3 milliequivalents. I don't need to upgrade to 3.5. I said from 3 to 3.5, I will be doing a oral correction. I can give oral pot chlor. Patient will be able to take orally and the bubble sounds would come back usually beyond 3. But from 2.3 to 3, because there is a IDS component also, so I have decided to give a IV correction to the patient. You can see mathematically here that the value mathematically rise in the blood is 0.7. So the formula that I will use is a simple one-step multiplication, that is 0.7 into 200. Mathematic, elementary. For 1, I need a 200 milliequivalent KCl. For 0.7, I'll multiply this and the requirement in the patient would be 140 milliequivalents of potassium chloride to be administered to the patient over 24 hours. This is the total correction that would be required in the patient. Suppose in this question value was given as 2.1. So from upgrading from 2.1 to 3, it would be a hike of 0.9. So I'll multiply 200 by 0.9. So whatever is the mathematical value given, you can just multiply that by 200 and you would be on your way to answer the correction for a patient having hyponatremia. Next up is the topic of hyperkalemia, and we'll discuss MCQ of NEET PG 2022, which said which of the following is used to decrease the concentration of extracellular potassium. Now, the first impression that my students told me was that, sir, we expected insulin to be present in the choices. I mean, you can immediately rule out glucagon in this question because we actually use insulin drip, and insulin is known to cause potassium to go inside the cells. But in this case, there was no mention of any insulin. Then one of my students said, sir, that you had told us that whenever potassium rises, it slows the heart. And because it slows the heart, it can contribute to development of bradycardia. So my thought process was that we should be giving atropine to the patient. So he did keep this in the options. Lactic acid. Well, if I give lactic acid to this patient, lactic acid, first of all, I mean, lactic acid is what you find to be present in patients who are having sepsis. I mean, serum lactate levels. So two choices were easily ruled out. Lactic acid, which is found to be elevated in patients with lactic acidosis, type A, type B, or sepsis, and glucagon. We are left between atropine and epinephrine. Now you have to make a choice, and to make you understand the answer to this question, let me just tell you regarding salbutamol, which is also used for treatment of patients of hyperkalemia. When we give salbutamol in hyperkalemia by nebulization, we usually use a dose which is 4 times higher than what is used in patients of asthma. Like all of you would have used Astelin, and you would have diluted it, and or maybe those respules are available nowadays, so you would have given salbutamol nebulization to an asthmatic. But the dose that we are using in hyperkalemia is 4 times more. Why? Because when you give lots and lots of salbutamol to the patient, let's look at what it does. Salbutamol will be a beta 2 agonist, that is okay, but it has a side effect also. It will also start causing tremors in the patient because salbutamol in excess can cause sympathomimetic stimulation. This sympathomimetic stimulation again contributes to sending potassium inside the cells. So just like you are aware that insulin causes potassium to go inside the cells, sympathomimetic stimulation also causes potassium to go inside the cells. I am giving so much of salbutamol that it is literally causing tremors in the patient because I'm using this concept of physiology, sympathomimetic stimulation / epinephrine, which is sending potassium inside the cells. The correct answer for this question is D, that is epinephrine. Had this question said that a hyperkalemia patient is having a bradycardia, yups, I would have been comfortable with atropine. But which of these drugs is best suited? See, atropine will treat only bradycardia, no? atropine is not going to treat the hyperkalemia component, but with epinephrine, what I can do is that I can neutralize the reason behind the development, or I can counteract the effect of potassium, because dangerous hyperkalemia, I would say like this, that dangerous drastic situations caused for unconventional approaches. The traditional method is obviously calcium gluconate, but it was an unconventional question. No? I mean, there were no regular stuff that is asked or we study in cardiovascular system, hyperkalemia drugs, that standard information was not given. So I would say unconventional situations cause for unconventional thinking as well. And it's epinephrine, which would be the answer to this question. The logic or the rationale behind it is what I've explained to you. And now let's look at in any patient of hyperkalemia where we can be having tall tentative waves, and we could be having is a ST elevation also. In these patients, let's look at what is the treatment that would be done for any patient having acute dangerous hyperkalemia. The mnemonic that we can use for this is CABG, coronary artery bypass grafting. So CABG D2. Now C here would be standing for calcium gluconate. You very well know that calcium gluconate does not cause potassium to go inside the cells. The main reason why we use calcium gluconate is mainly for antagonism. I mean, I just want to antagonize the effect of potassium on the heart. Potassium slows the heart, potassium relaxes the heart, and calcium contracts. C for calcium, calcium contracts, potassium relaxes. So I'm just trying to counteract the relaxant effect of potassium on the heart. I'll be also using albuterol in these patients. A in CABG would stand for albuterol / salbutamol nebulization, and the dose that I'll be giving here will be much higher than the conventional dose that I use in asthma. Then just for completion of mnemonic, I've made it CABG, but bicarbonate per se. Remember, bicarbonate is not used routinely. When would you use soda bicarbonate is only when a person is having metabolic acidosis concomitantly, like in patients of kidney disease. If a patient is having, let me say, acute kidney injury, severe metabolic acidosis is present, and at the same time a dangerous hyperkalemia, then I can counteract the acidosis component. And the logic behind this is pH has inverse relation with the potassium value. So if I give bicarbonate, I'm causing a rise of potassium, and therefore the rise of pH of the patient. If I give bicarbonate, it will cause the pH to rise, and if the pH will rise, then the potassium values will fall. This rule will help you lots of time. pH shows an inverse relation with potassium. So my objective is to upgrade the pH and thereby reduce the potassium values. Then I'll be using CABG mnemonic glucose with insulin. I mean, whenever we give insulin drip to the patient, it is also having simultaneously glucose as well. The objective of giving insulin to the patient would be to send potassium inside the cells, and this insulin drip is one of the most effective drugs. I did not use the word most effective method. I said most effective drug to treat dangerous hyperkalemia. A patient having potassium values going up to 7.58, because it can cause a diastolic arrest, I would like to use insulin drip, and it will cause a fall in the values of potassium. The magnitude of fall that you will encounter after giving this drip to the patient would be about 0.5 to 1 milliequivalent per hour. So within few hours, you will stabilize the patient. Then I can also be using diuretics like loop diuretics. Lasix can be used. And the objective of using Lasix will be, it will be causing polyuria, that is urinary loss of potassium. You can understand that in insulin drip, I was causing a redistribution. It was going inside the cells, so I was causing a redistribution. But in diuretics, I'm causing a loss. It's a urinary loss of potassium. And then I can also be using dialysis. For dialysis, the question to be remembered will say, which is the most effective method? So please be clear. If he says most effective drug to treat this patient of dangerous hyperkalemia, you can go in for insulin drip if he says drug. But if he says method, then hemodialysis will always be superior. And in case he gives you a case of CKD with elevated potassium, let me say potassium is 6 milliequivalent. And this has been, so patient says, sir, this has been the value for last 2 months or 3 months. And that's when I decided to, he might be got this test done complimentary from, because these laboratories will be doing this complimentary health checkups done. So, and this CKD patient potassium was beginning to rise because now GFR is falling. You know, earlier he could have been CKD grade 4, 5. Now it's downgraded to CKD 3, CKD 2 grade. So therefore potassium will rise. For these patients, we shall be using a novel agent, that is patiromer. Drug of choice for chronic hypernatremia is patiromer, and another agent that we used to use even earlier is available even at the moment also. It can be given orally or it can be given in the form of enema, is SPS, that is sodium polystyrene sulfonate. The brand name you read is K-Bind. So K-Bind is sodium polystyrene sulfonate that can be given in the form of enema format to these patients weekly to treat the chronic hyperkalemia component. This slide, parts of it have been also discussed in the earlier part of the discussion, where I've talked about in cardiovascular system, where I've talked about ECG findings with respect to both of them, actually hyper and hyponatremia, and I have highlighted the drugs component in this particular slide. Next up, I'll be talking about magnesium. Magnesium deficiency will usually be encountered in pediatric cases where there is persistent diarrhea and in adults with chronic diarrhea. Then alcoholics because of nutritional reasons, thiazides because they would be acting on the distal tubule. Both with thiazides and Gitelman syndrome, there is a common thing in the distal converted tubule, which is a receptor by the name of TRPM6. This is responsible for magnesium reabsorption. Both thiazides will block this TRPM6, and Gitelman anyway is a congenital defect due to which TRPM6 is not working, and therefore there is magnesium wasting occurring in the patient. Both of these causes magnesium wasting, whereas in alcoholics it was deficiency. It was a dietary deficiency. Now magnesium per se, remember my statement, how to remember aspects with respect to magnesium. Then the data to be remembered is like this, that magnesium per se antagonizes the effects of calcium which is present, let me say, in the blood vessels. Magnesium tends to antagonize the effect of calcium. Calcium causes vasoconstriction, and magnesium causes antagonism of this intracellular calcium, which causes vasoconstriction. So suppose magnesium is less in the patient. If there is going to be less magnesium, then this antagonism will be less. I repeat once again, let me put some arrows. If magnesium is less, then this antagonism will also be less. And if the antagonism of intracellular calcium will be less, then calcium will be able to cause a constriction, and because of this exaggerated vasoconstriction, you could be having is an increase in the blood pressure of these patients. So hypomagnesemia behaves like one hypokalemia. In fact, if you're listening to the this discussion, whether in the main videos and even today I've said, I'll just go back to this slide, that patients who are having hypokalemia also, they could be having a simultaneous deficit of magnesium as well. Hypokalemia and hypomagnesemia can coexist in a single patient, and clinical manifestations of hypomagnesemia, some of them mimic that of hypokalemia. So muscle cramps is one thing which is common between both of these conditions, but then there would be differentiating features which would come up is like hypertension, which the logic I'll say once again, and the logic was that magnesium antagonizes the effect of intracellular calcium. Now this antagonism is lesser, which explains the increase in blood pressure. In fact, in these patients there is also a risk of development of torsades de pointes. Both hypocalcemia and hypomagnesemia predispose to torsades de pointes. In fact, let me just jot down which electrolyte imbalances predisposed to development of torsades de pointes. It would be hypokalemia, and hypomagnesemia and hypocalcemia as well in some situations can trigger this, though hypocalcemia will cause tetany earlier and carpopedal spasm and laryngospasm as well. Then there can be increased neuromuscular excitability, and therefore person could be having tremors, nystagmus and episiotosis. For management of this patient, we will have to give magnesium sulfate. This magnesium sulfate, depending on the deficit, can be given either parenterally, that is either intramuscularly or intravenously, and we also have as oral salts also available to take care of the deficit of magnesium. Now the opposite of this, which is hypermagnesemia, is what I'll focus next. The normal values are in the range of 1.3 to 2.1, and we are having a patient where values are going up to 4 or 5, and if the values go more than 10, then the heart can stop. It can be asystole. Last time I taught you potassium can cause heart to stop. There could be diastolic arrest in the patient. Now I'm teaching you magnesium in excess can also cause the heart to stop. Important reasons for hypermagnesemia can be one, in impaired excretion with respect to the kidney. That is, instead of wasting, there is no excretion happening. That could be CKD. Or it could be a case of eclampsia where magnesium sulfate by the Pritchard regimen was given, and overdosage of that can result in hypermagnesemia occurring in a patient, and then could be antacid or laxative abuse. Both contain magnesium salts, so excessive intake of magnesium salts can explain the hypermagnesemia component. Let's look at the earliest feature that will develop in the patient. If he says what is the earliest feature to develop, do not answer hyporeflexia or areflexia. The earliest feature will be that of shock. Now the logic is magnesium will antagonize intracellular calcium. If you antagonize the intracellular calcium, then the calcium will not be able to cause a vasoconstriction, and because vasoconstriction cannot happen, therefore the person could be having a shock which is non-responsive to IV fluids. Normally calcium maintains the tone of our blood vessels. You see, normally calcium in the intracellular calcium in the blood vessels helps in maintenance of vascular tone. Now this is overridden, and if you override the normal vasoconstriction of blood vessels in the body, there would be a shock-like manifestation which is not going to respond to IV fluids and vasopressors, because vasopressors also require vasoconstriction to occur, for which intracellular calcium would be required, which is being antagonized by excess of magnesium. Then would be the standard things that even the obstetrician will talk about, that is DTRs will reduce because neuromuscular excitability increases. Remember, it's opposite, right? When magnesium in the patient is less, the neuromuscular excitability is increased. If it is more magnesium, the neuromuscular excitability becomes relatively lesser. And this explains why are you reading the statement that deep tendon reflexes in these patients would be lesser, the urine output of the patient would be lesser, and the respiratory rate will also decrease. But if he says what is the reason for death, then do not answer respiratory arrest. Primarily answer it as asystole. And for management of this patient, you need to give vigorous hydration, but the treatment drug of choice would be answered as calcium gluconate. So calcium gluconate, where do you use it? Calcium gluconate is 10% calcium gluconate is useful for management of tetany. Calcium gluconate is also useful in dangerous hyperkalemia, as I just explained on my previous slide to you. And just now I've taught you that if a patient is having hypermagnesemia to dangerously high levels, maybe going up to maybe double, triple of normal. I mean, I'm not saying going up to 10 because then we lose the patient. But if it is dangerously high levels, then calcium gluconate can be used to counteract the effect of magnesium here. So these are 3 uses of calcium gluconate that you also need to remember. Now what we will do in the subsequent table will be that I have just mentioned, you don't need to remember these mathematical values of less than or more than, but you need to remember what are you going to do to handle the patient's presentation. I mean, if it's a dangerous hyponatremia, the fluid that will be used for correction would be 3% saline. But if it is dangerous hypernatremia, then I've told you already 5% dextrose. Similarly, if potassium is elevated, then I shall be using calcium gluconate. Calcium gluconate will be answered multiple times here. So let's go stepwise. Then if it's potassium becoming less, diaphragmatic paralysis, I will give potassium chloride. Remember that rule, to rise 1 milliequivalent in the blood, I need to give 200 milliequivalents of KCl to the patient. So that rule is to be remembered. Always give potassium chloride and add it to IV fluids in the patient. Do not give it directly, otherwise a patient can develop a diastolic arrest. If calcium is grossly elevated, then the first step in the management is hydration. For both hypermagnesemia as well as hypercalcemia, vigorous hydration of the patient is important. But the drug of choice for dangerous hypercalcemia is bisphosphonate, which will send calcium inside the bones, and this bisphosphonate is given intravenously. So I'll be using ebandronate in the patient. A person is having tetany, carpopedal spasm, Chvostek sign coming up. Carpopedal spasm and then Chvostek sign, the twitching. If you tap on the anterior part of the parotid gland, the facial nerve branches would be irritated and there would be quivering of the lips. There would be twitching of muscles around the lips. So circumoral muscle twitching will be noticed. That's again where you shall be using calcium gluconate for effective management of your patient. If potassium is very, very high, then again it is calcium gluconate. But if magnesium is very, very less, it can cause torsades de pointes, polymorphic ventricular tachycardia. So I need to give magnesium sulfate to these patients parenterally, or even magnesium oxide. I mean, if the patient is sick, obviously it would be a parenteral administration. Once he recovers, then oral administration in the patient would be started. This table, guys, is I would say important. And I mean, if you can just jot down all these points by yourself, this particular table, you would be in a much better frame of mind to handle those questions. Because I know you brilliant chaps, you obviously can remember and simulate all this data, but then in the exam you need to do it faster also. So it's not only about speed, it's not only about accuracy, it's about speed also. It's a combo of accuracy and speed which will help you get to the desired score. So that's why I recommend you to note down this table in your own handwriting so that you can remember the information, which this should be like permanent imprint into your brain, that your brain like a computer retrieves the information just like Google does in a search of 0.02 seconds. It shows no that the data was retrieved in these many seconds. So similarly here, I want a fast retrieval for the topic of dyselectrolytemia. So let us solve a question that was asked in NESET May 2022, and the question said which of the following drugs is not used in hyperkalemia. Fairly an easy one. Salbutamol nebulization works by causing sympathomimetic stimulation. I've explained to you that this would contribute to potassium to go inside the cells. Insulin and dextrose combination will also work in the same fashion, and calcium gluconate is mainly given for antagonism. The answer for this question will work out to be option number B, that is magnesium sulfate. We have studied magnesium sulfate for management of eclampsia as well as for management of patients who are having Torsades de Pointes. Now moving to the next concept, that is about anion gap. Usually they ask about urinary anion gap and the standard plane anion gap as well. I'll first focus on the urinary anion gap. The formula for urinary anion gap does not incorporate bicarbonate. It is sodium plus potassium, and from that the positive charged ions you would be subtracting chloride. Now I want to draw to your attention at this moment that when we are going to discuss anion gap, and I have done that in the main videos as well, in discussion of the anion gap, potassium is not taken into consideration. But when you are calculating urinary anion gap, you will be taking into consideration potassium, and that will not be potassium in the blood. Obviously, that would be potassium in the urine, sodium in the urine, and from that you are subtracting urinary chloride. Then the question arises, what is the normal value for urinary anion gap? The normal value would be given by you as 0. The basic function of the kidney is to maintain electroneutrality. I mean, the positive charges and the negative charges are lost in equal amounts, so they cancel each other. Now let's take up a case of diarrhea. In any patient of diarrhea where there would be severe dehydration occurring, the perfusion of the tissues will be hampered, and every time the availability of oxygen to the tissues is less, the perfusion of the tissues is less, they switch over to anaerobic mode of respiration, which results in generation of lactic acid and protons. So every time you have a diarrhea patient who is going into severe dehydration, he will end up with metabolic acidosis, because there is generation of protons in the body. One, to neutralize these protons, we can give ringer lactate, because lactate will produce bicarbonate, and this bicarbonate which is produced will neutralize the hydrogen ions. And at the same time, because there is more of hydrogen in the body, then this hydrogen will also be lost by the kidney, because after all, if you have more of hydrogen, H plus in the body, you need to get rid of it so that the pH can come back to normal. Now the next statement that I say is very critical. When I'm saying there is going to be hydrogen loss in the urine of an individual, at that point of time, the kidney will step in to maintain EN. EN means electroneutrality. And because positive charges are being lost in the urine, the kidney will try to counterbalance them by increasing the amount of urinary chloride also. So what I'm saying is that urinary chloride values will begin to rise, and rest is mathematics, that if the negative charges will rise, if you look at the formula, sodium plus potassium subtracted chloride from it, if mathematically speaking the chloride values will rise, then this urinary anion gap value will become lesser. Just as an aid for remembering, instead of writing the word negative the way it is written, I am just introducing the word gut here, just a change of spelling to make you remember that in a gut cause, that is diarrhea, the urinary anion gap would be negative. The opposite of this would be that the urinary anion gap is positive in renal tubular acidosis. Let's look at the logic behind that also. In renal tubular acidosis, the main problem would be that even if there is going to be H plus in the body, it cannot be excreted. Renal tubular acidosis is mainly characterized by impaired hydrogen excretion, and therefore the logic that you need to now remember is that if hydrogen will not be excreted in the urine, if there is going to be less hydrogen in the urine of the patient, then there will be less urinary chloride also. And if I'm now going to change the arrows in this particular case, earlier I was saying that the urinary chloride is more. Now in this case, the urinary chloride will become lesser, and mathematically you can see that if chloride values are lesser, then this mathematical value will tend to increase, and is explaining the fact that why did I write positive urinary anion gap for patients of renal tubular acidosis. The basic summary is, and I mean, in the exam, I agree that you would not have time for such logic that I'm describing, but I'll just try to explain that once again in the shortest possible time frame so that you can remember it. You see, in this formula, if urinary chloride is less or more, that will impact the final mathematical outcome. In diarrhea, kidneys are working fine. In diarrhea, there's a dehydration occurring, but the kidney is able to excrete hydrogen. And because positive charges are being lost in the urine, therefore, to balance it, even urinary chloride values will rise. The kidney will excrete negative charges also. So, if chloride values rise, the anion gap value will reduce. Vice versa, I've shown for renal tubular acidosis. Because the concept of anion gap is taught even in physiology, I thought that first I should touch not on anion gap, but I should touch on UAG, urinary anion gap, and the must-know facts are the ones which I have highlighted in this box before you. Now we are going to look at the routine formula for anion gap. That would be sodium minus chloride and bicarbonate. Potassium values will be given in the question. You will be given potassium in the blood in this formula, but you need to neglect that mathematical value. Just consider sodium and chloride and bicarbonate, and I'll just make you practice it mathematically so that it becomes easier. You see, sodium in the body normally is between 135 to 145, so let's take an average of 140. Chloride in the body, this would be in the range of about 96 to 106. So just for calculation purposes, I'm taking this value to be 106. And bicarbonate, I'm taking an average of 24. That I have done this activity only for ease of my calculation. Now, if you do simple mathematics here, 140 minus 130, that would be 10. And I told you the normal anion gap value in us is about 12 milliequivalents. Now, there would be conditions where you would be having a increase in anion gap, and you could be having conditions where there would be a normal anion gap in the patient, and therefore the terms that would be used would be HAGMA, that is high anion gap metabolic acidosis, or it would be NAGMA, that is normal anion gap metabolic acidosis. The anion gap values are also dependent on serum albumin values. If serum albumin is affected, if serum albumin is lesser, like in cirrhosis or in nephrotic syndrome, then anion gap values also need to be adjusted, and the anion gap values will also fall by 2.5. In the exam, it's unlikely that he will give you a situation and calculate the anion gap where albumin will also be given to be lesser. But I just wanted to bring to your notice the fact that albumin itself has a negative charge. So the point is why the correction is being considered is because it again contributes to the negative charge in the body. Now, once you know the normal values, we'll focus on some formulas which will help you remember normal anion gap metabolic acidosis versus patients who are having a high anion gap metabolic acidosis. For NAGMA, the formula or the shortcut or the mnemonic I want you to remember is Dr. Fuse. The first one is diarrhea. The logic is positive and negative charges both would be lost in equal amount. Therefore, the anion gap value will remain constant. Alphabet R would stand for RTA, that is renal tubular acidosis of any of the three varieties, RTA 1, 2 and 4 will be having a normal anion gap. Again, the logic is positive and negative charges are lost in equal amount, so the mathematical value remains the same. The F of Fuse will stand for fistula. Now, the fistula that you will read about would be like enteric fistula or pancreatic fistula, or you could read about enterocutaneous fistula. Whenever in GI tract you read about Crohn's disease, then patients of Crohn's disease can develop an enterocutaneous fistula, and there would be loss of electrolytes from the body, both positive and negative in equal amounts. So therefore, the anion gap would remain constant. The use word USC, the more I would say these three terms, some of them are silent in this mnemonic, and it is ureterosigmoidostomy. So you just need to remember the four important causes, and it would be all except MCQ, where NAGMA would be compared with high anion gap metabolic acidosis, the mnemonic for which is CULT. Now in CULT, the first one is ketoacidosis. He can give you a scenario of an alcoholic having ketoacidosis. It could be a farmer who has gone on hunger strike and post starvation is ending up with ketoacidosis, or the traditional diabetes mellitus patient who ends up in ketoacidosis as well. Then would be uremia. For uremia, it could be acute kidney injury, it could be chronic kidney disease, or you could just use the word kidney failure. In fact, if you read this word kidney failure, I agree that it will look like simple English, But if you read the current definition with respect to CKD, then kidney failure as a word means that the glomerular filtration rate of the patient would be less than 15 ml per minute. Normal glomerular filtration rate will obviously be in 3 digits, right? Here I'm talking about double digits being present in a patient. 125 ml per minute, and I'm talking about 100 ml per minute, 1.73 meters square of body surface area. So the term that we used to study in the books was ESRD, that is end stage renal disease. But you will notice, and I'll show you that slide also of the KDIGO classification for chronic kidney disease, which mentions the word kidney failure for GFR less than 15. I mean, it's a very broad spectrum English word, no, kidney failure, but in the classification is mentioned it for GFR less than 15. So any of the causes of patients having AKI, which could be maybe a scenario of hepatorenal syndrome, or it could be a renal cause, intrinsic cause like hemolytic uremic or thrombotic thrombocytopenic purpura. For CKD, it could be diabetic nephropathy, analgesic nephropathy. Any of those causes that you are aware for AKI of the various varieties or CKD, they would all contribute to high anion-gap metabolic acidosis, hydrogen ions being generated in excess. Then would be lactic acidosis, which would be of two varieties, type A and type B. Now, what is the difference between type A and type B lactic acidosis? That I'll explain on my next slide. But at the moment, I just want to fill in the mnemonic here. And at the moment, all I can say is for type A, it would mainly be hypoperfusion state, especially if there is shock, any kind of shock, cardiogenic shock, distributive shock, septic shock. It will cause underperfusion of tissues. It will cause cells to switch to anaerobic mode of respiration, and lactic acid would be produced, and that will cause type A lactic acidosis. Then can be toxins, the standard methyl alcohol poisoning, ethylene glycol poisoning, that is the antifreeze. I mean, instead of writing the word ethylene glycol, he can mention about antifreeze. And then you could be having a glue sniffer, and in glue sniffing, you very well know about toluene. In fact, in the question, he can also incorporate antidotes which can be asked. I mean, he might say all are correct about the statements given. So for methyl alcohol poisoning, the main antidote that we use is fomepizole. And if he says in ethylene glycol poisoning, why is there gonna be a acidosis? Then in ethylene glycol poisoning, there is a crystalluria. Let me say this is the tubules of the kidney. Then in ethylene glycol poisoning, what happens is that there is calcium oxalate crystals that would accumulate and they would block the kidney. These calcium oxalate crystals will cause development of acute tubular necrosis. I said crystalluria. I said there would be calcium oxalate crystals which would block the tubules, and if the tubules are damaged, then one of the important functions of the tubules in the kidney is excretion of hydrogen. If that does not happen, that will explain metabolic acidosis developing in the patient. And the antidote for ethylene glycol poisoning. For methyl alcohol poisoning, I mentioned fomepizole, and we also read about ethyl alcohol, and we read about retina being damaged and blindness. Ethylene glycol poisoning, if he says what is the antidote, your answer would still be given as fomepizole for the patient. So this is an important slide, I would say, especially FMG exam. I mean, every session that you are going to go through the questions, you will notice at least one question on in an all accept fashion with respect to NAGMA versus HAGMA. And as far as the causes of lactic acidosis type B are concerned, I'll explain them on my subsequent slide before you. When it comes to lactic acid levels in the body, it would be between 2 to 4 millimoles per liter. Anything more than 4 would mean that there is lactic acidosis occurring, and as I told you, type A would be due to hypoperfusion. So he can mention about cardiogenic shock or distributive shock or any kind of shock per se. The bottom line is ultimately the tissues will have to switch to anaerobic mode of respiration. But if he talks about conditions like diabetes mellitus, I am not talking about at the moment diabetic ketoacidosis. I'm talking about diabetic patients could also be having lactic acidosis. In fact, one of the drugs that was banned, and I mean, I'm not saying that only fenformin in diabetes is the cause of lactic acid. Diabetes mellitus itself can result in lactic acidosis. That is one. I mean, diabetes mellitus patients are predisposed to infection, no? And this infection can result in development of sepsis also. So you could be having lactate generation. That is one. And then drugs per se, fenformin was withdrawn from the market because it causes lactic acidosis. Even metformin can cause lactic acidosis, but only if it is given in a patient in whom the eGFR of the patient is less than 30. I can just mention it here. Metformin is one of the primary drugs that we use in type 2 diabetes mellitus. Metformin ideally should be stopped if the estimated glomerular filtration rate of the patient is less than 30 ml. It's the range actually 30 to 45 ml. But anyway, if the value is less than 30 and the doctor still keeps on giving, the doctor did not calculate the eGFR of the patient, I'll teach you formulas also like CKD, EPI, MDRD, and then Cochrane Gold formula that you read in physiology also. So those formulas will also be discussed for calculation of GFR. But the point is, if any diabetic nephropathy patient is on metformin, and metformin ideally should be stopped at the values that I mentioned. If it is not, then it can also contribute to lactic acidosis. Similarly, patients on liver disease, malignancy, and TPN are predisposed to development of lactic acidosis. So you can see that any of these causes could be given in the question with respect to HAGMA. The details for HAGMA are fairly extensive. Mostly the mnemonics that you will read for this would be like mud piles, etc. But instead of talking about mud piles, I'm talking about cult. I've concised the information, but everything that is present in the bigger mnemonic is present here also, because this lactic acidosis causes are the ones on the basis of which various more fancy mnemonics have been created. More is the number of alphabets in the mnemonic, more liable you are to forget it. So do not go for those longish mnemonics, the traditional ones, because you are not gonna usually get situation like paraldehyde data being given to you. You know, when you read mud piles, no paraldehyde comes up, isoniazid comes up. It's unlikely. If you go through the questions of the previous years, this that I'm telling you would be sufficient. The only thing is you need to elaborate on the causes of lactic acidosis, which have been told to you in this particular slide. We will now start with a topic in kidney that you all have been waiting for, that is nephrotic syndrome. Fairly a straightforward topic, where I'll first be teaching you essentials of diagnosis. One of the important features for diagnosis of this condition is massive proteinuria. The traditional definition for massive proteinuria would be more than 3.5 grams of protein present in the urine in a 24-hour period. Now the problem is that this would require a 24-hour collection, and with 24-hour collection there could either be an under collection or an over collection. Like you gave a specific, you gave a special, bottle to the patient, and you said that you are not to urinate in the toilet seat, but you have to urinate in the bottle. And when the person went to the bathroom, he just forgot the bottle is in the washroom. But they might actually forget and urinate in the washroom and then remember, oh, the doctor asked me to collect the urine sample. So lots of time you have practical problems, and either there is an under or an over collection happening. To prevent this from happening, what we are doing at the moment is that instead of going in for a timed 24-hour collection, which has logistic and administrative issues, what you can go in for is a spot urinary sample. And in the spot sample, you would be checking for the protein. And in this case, the denominator will not be per day, obviously, because we are taking a spot sample. The denominator will be per gram of urinary creatinine. Lots of time in the exam, they have asked what is the cutoff for massive proteinuria, and they have not asked this with respect to per day. They're not asking per day. They're asking what is the cutoff with respect to, how many grams of protein should be present per gram of urinary creatinine. So the answer of yours would be given as, and I usually find errors on the part of doctors while answering this, that is more than 2 grams. They answer 3.5 for what is mentioned currently in color black. It's not 3.5. The 3.5 is for a 24-hour collection. The 2 gram value is for a spot sample, which will be more convenient, handy for you. Now, if we are going to evaluate any patient on nephrotic syndrome, one of the classical forms is minimal change disease. In pediatric age group, we have mainly loss of albumin. Well, I'll be teaching you forms of nephrotic syndrome where you could be having is a non-selective proteinuria. Non-selective means that low molecular weight and high molecular weight products are also lost. High molecular weight would be like ferritin is also lost, or ceruloplasmin is also lost. So in nephrotic, you could be having even ceruloplasmin loss. The point is, in routine forms of nephrotic, like minimal change disease, we have is only low molecular weight proteins being lost, like albumin. So one of the important diagnostic features of the disease would be hypoalbuminemia. Now, because albumin will be lost from the body, this is going to cause a reduction in the oncotic pressure, and this will explain the edema component that would be coming up in the patient. The important components for diagnosis of nephrotic syndrome are having alphabet O. Proteinuria is having a O, hypoalbuminemia, hypo is having a O, and then edema component is also having a O. And whenever you're going to talk about edema and nephrotic syndrome, you will also notice that this edema will usually begin off around the eyes of the patient. In heart failure, the edema starts from the feet, but in nephrotic syndrome or in kidney disease, you will notice that initially there would be a periorbital edema, then it will tend to reduce as the day will progress because the patient will be standing straight up, and the edema might appear around the genitals. So especially with respect to a girl child with minimal chain disease, you might read about the girl child having difficulty in urination due to vulval edema. Similarly, there would be scrotal edema as well, but it may not be brought to notice of the mother, and then subsequently the edema will migrate to the feet. So most of the time in nephrotic syndrome, he might try and describe to you this diurnal variation with respect to the edema that a observant mother might be able to see, or an adult person might be able to appreciate. The top three that I have mentioned before you are referred as essentials or diagnosis. I mean, they have to be present. Just like in nephritic syndrome, you always read about hematuria with hypertension and a subnephrotic proteinuria. Subnephrotic would mean lesser than the values that I told you, less than 3.5 on a 24-hour basis and less than 2 on in a spot sample. The denominator in the spot sample, I repeat again, was gram of urinary creatinine. These are three essentials or diagnosis in contrast with nephritic. Now, other features that can be present in this condition, but why is it not an essential or diagnosis, is because hyperlipidemia can be present with multiple reasons. No, even diabetic patients can be having hyperlipidemia. Even SLE patients in later stages after 45 could be having a hyperlipidemia. So we do get accelerated atherosclerosis in nephrotic syndrome. Yes, guys, you read about accelerated atherosclerosis with respect to multiple conditions in endocrinology like diabetes mellitus or hypothyroidism or even metabolic syndrome. T4 lesser here is the representation for hypothyroidism, then metabolic syndrome. Then even rheumatoid conditions like SLE and rheumatoid arthritis, they can be having accelerated atherosclerosis. But today I've told you even nephrotic is one of the causes of accelerated atherosclerosis. Now, if there's going to be more lipids in the blood, it can also cause lipids to come in the urine, lipiduria, very peculiar condition. But then do you read about fat in the urine in any other condition? Then yes, we do read about fat in the urine. One in patients who are having, apart from nephrotic syndrome, condition where there is fat in the urine can be fat embolism syndrome. FES here is the short form for fat embolism syndrome. Then you can also have fat in the urine with respect to chyluria. Why is chyle coming in the urine? That would be mainly in filariasis. So why lipiduria is not essential or diagnosis is because it can be seen in fat embolism, chyluria and nephrotic syndrome as well. And another term that the examiner might use in a lot of MCQs on nephrotic syndrome, instead of saying the word lipiduria, he will imply lipiduria by saying this word oval fat bodies. So point number 5 is not an essential or diagnosis due to reasons I've explained. And then nephrotic is also a hypercoagulable state. I agree, pregnancy is a hypercoagulable state, factor V leader mutation is a hypercoagulable state, but why is nephrotic a hypercoagulable state? Well, the logic here is that there is a urinary loss. I told you there can be loss of not only albumin, I told you there could be loss of ceruloplasmin, ferritin. So no big deal that there could also be urinary loss of protein C, protein S and antithrombin 3. And what are they? They are the anti-clotting factors. Imagine a situation where in the body the clotting factors are there, but the anti-clotting factors are lost in the urine. Normally the clotting and the anti-clotting, they keep each other in check. If you lose anti-clotting system from the body, the clotting system would be acting unopposed, which explains the fact that there would be a hypercoagulable state in the patient. Apart from this, you will also notice that in patients on nephrotic, lots of time, because it's also an inflammatory state, fibrinogen levels may be even elevated. It can be normal also, no big deal, it can be normal also, but are usually found to be elevated. So there are two reasons why this is a hypercoagulable state. But hypercoagulable state can be found even in antiphospholipid antibody syndrome, pregnancy, factor V latent mutation, so many reasons. So because 4, 5 and 6 can be present in multiple other conditions, we have not included them in the essentials of diagnosis of nephrotic syndrome. I mean by the word primary nephrotic syndrome versus secondary nephrotic syndrome. When it comes to primary, it means causes that you traditionally read in pathology like FSGS or MGN. Focal segmental glomerulosclerosis is the most common cause of nephrotic syndrome in adult population. But if we will ask you what is the leading cause of primary nephrotic syndrome in geriatric population after 65 years of age, your answer would be given as MGN, that is membranous glomerulopathy. But if he talks about secondary nephrotic syndrome, then the causes could be like diabetes mellitus or amyloidosis or lupus nephritis. Lupus nephritis, you read in pathology also that very classical term wire loop lesions. And another finding that you see with immunofluorescence study in these patients would be akin to multiple cards present. So we read about a full house effect. I would like you to read about the full house effect in the rheumat section in SLE, where I have explained it more in detail. But these patients subsequently can be having significant damage in the kidney and could be having nephrotic range proteinuria as well. So though I've written the word nephritis, that's the initial presentation, hematuria with hypertension, but later you could be having a nephrotic range proteinuria in these patients as well. For amyloidosis, I can remind you that the organ that is most commonly involved in amyloidosis and causes enlargement of the kidneys, I mean both kidneys are enlarged in amyloidosis, and you have is a nephrotic range proteinuria. If he says which organ involvement in amyloidosis leads to death, kidney is the most common involved, but the one that leads to death is the cardiac involvement. Restrictive cardiomyopathy can develop due to amyloidosis, which explains the reason for death. But the commonest organ involved in amyloidosis is kidney, and you could have is a secondary nephrotic syndrome and a protein amount more than 2 gram, a gram of urinary creatinine. We'll now focus on the type of nephrotic syndrome which is commonly seen in adults, that is focal segmental glomerulosclerosis. Lots of time this diagnosis is missed. You see, whenever we study about the kidney, we read about the cortex and then we read about the medulla, and we also have is a corticomedullary differentiation present, which is always made out both by the radiologist, and even in pathology in the cut section you can make out the cortex and the medulla. Now the problem with focal segmental glomerulosclerosis is that mainly the disease is concentrated at the corticomedullary junction, because the disease is initially focused mainly in this particular area, corticomedullary junction. If you're going to do a biopsy of this patient, a kidney biopsy of this patient, and let me say the needle went only up to the cortex, if the sample was taken superficially, then this particular side, I mean the site, the commonest one I said is corticomedullary junction. If the biopsy needle will miss this site, then the diagnosis will be missed, and this person will be misdiagnosed as minimal chain disease, because you know that in minimal chain disease light microscopy is normal, and here also light microscopy will turn out to be normal. The problem is very much there. Problem is very much there at the corticomedullary junction, but because your needle did not reach up to this area, therefore there is high chances of missing the diagnosis. So in these patients, one, I can say that the importance of doing a ultrasound guided kidney biopsy makes sense. And we will also study regarding the important causes why focal segmental glomerulosclerosis is asked in the exam. He will talk about and divide this discussion again into two parts, primary versus secondary. And with respect to secondary, the most important cause which is always asked in the exam is HIV associated nephropathy. In fact, focal segmental glomerulosclerosis could be having enlarged kidneys. What are the conditions where you will read kidneys are enlarged? In pathology, they always tell you enlarged kidneys is a feature of amyloidosis. Even in pathology, they say this, and even I have said it at the moment, HIV associated nephropathy. Even in diabetes mellitus, you have is enlarged kidneys present. Then instead of HIAVN, that is HIV associated nephropathy, he can write focal segmental glomerulosclerosis, because HIVAN is one of the forms of it. And then obviously autosomal dominant polycystic kidney disease with defects in chromosome 16 and 4 respectively. I mean, you could be having is bilaterally enlarged kidneys. Then is hepatitis B virus and human parvovirus B19. At this junction, I would like to introduce a question here, which is hepatitis C is associated with development of, then your first answer would be MPGN, that is membranoproliferative glomerulonephritis. When he talks about hepatitis B, then it is associated with focal segmental and MGN. On the next slide, when I describe the geriatric age presentation of nephrotic syndrome, you will see hepatitis B will come up again. But hepatitis C, one you need to remember for association with membranoproliferative glomerulonephritis. Yes, the same MPGN where you also read about a tram track appearance on a kidney biopsy. You read about tram track appearance on X-ray or on a CT head with respect to Sturge-Weber syndrome. You read about a tram track on a CT chest with respect to bronchiectasis. I'll repeat that again. I have discussed that in neuro also. Tram track on X-ray skull / on a CT head, that would be Sturge-Weber syndrome. Tram track with respect to a CT chest, a HRCT chest, that would be bronchiectasis. But a tram track with a kidney biopsy, it would be membranoproliferative glomerulonephritis. And in fact, I should write it separately instead of mixing it up with bilaterally enlarged kidneys. This is a finding on a biopsy of the kidney, and causes of bilaterally enlarged kidneys I have mentioned here. I did not include hydronephrosis there because that would usually be due to maybe a pelvic-ureteric junction obstruction, and it may be unilateral also. I mean, ureteric fibrosis or ureteral strictures can also contribute to hydronephrosis, but then hydronephrosis can be unilateral also. Human parvovirus B19 is what you study very commonly with aplastic crisis. Whenever in hemat you are studying about especially I would say sickle cell anemia, or even when you're reading about hereditary spherocytosis, you read about this organism. And then even in pediatrics, they talk about erythema infectiosum, where the baby will be having a slap cheeks appearance. Was a old, I think it was a FMG exam question, only child shown slap cheeks appearance. Then the question mentioned that the kid is having this viral exanthema. The slap cheeks appearance was shown, and we said which virus is responsible, human parvovirus B19, and it is also incriminated in causing FSGS. Then 3 drugs are to be remembered: heroin, pamidronate, and lithium. Prior to this, I've told you an important question that lithium is one of the important causes for development of nephrogenic diabetes insipidus. But today, I want you to remember this as one of the causes mentioned in the textbook for FSGS as well. The next cause, which is very important to be remembered here and should be given its due respect after HIV-associated nephropathy, is reflux nephropathy. 2 very important MCQs of the previous years, PYQs, where he has asked about FSGS association is HIV-associated nephropathy and then a reflux nephropathy. Other causes you can just go through: hypertensive nephrosclerosis, Alport syndrome, and sickle cell anemia. Alport syndrome is what you read with respect to a defective gene, that is type 4A collagen, and it is called 4A gene, which is found to be defective. In Alport, you would be having lenticonus, anterior lenticonus, sensory neural deafness, and then hematuria and end-stage renal disease as well. These are some of the important causes of FSGS which should be remembered. And then we also have electron microscopy findings of FSGS, which I will talk about in the subsequent part of the discussion. But yes, do keep a watch for, and if you're aware from pathology, I think you should be able to recall it, because a lot of questions of FSGS would be solved by you on basis of electron microscopy finding that would be given. Obviously, age will matter, nephrotic range proteinuria will matter, but then if electron microscopy findings are given, they help you in solving the question relatively better. When I say the word focal segmental, it is understandable that there would be a collapse of the glomerulus subsequently, but initially only some part of the glomerulus will be the one which will be eosinophilic. If I just draw a crude diagram representing it, though you can read about this from pathology, if this is the glomerulus, you will notice that some part of the glomerulus will be completely eosinophilic. I mean, there would be eosinophilic presentation or eosinophilic deposit present in some segments of the glomerulus, and this is grossly different from diffuse glomerulosclerosis. This was focal segmental. In diabetes, you read about diffuse glomerulosclerosis and nodular glomerulosclerosis. So we will talk about diabetic nephropathy when the time comes, but at the moment, details for FSGS, everything that I have mentioned here is even taught in pathology. It's a repeat, and each one of these words that I've said are questions from previous years. Especially the data in green should never ever be forgotten. Now we will compare this information with that of MGN, that is membranous glomerulopathy. And my first job would be to tell you regarding when it comes to MGN in a person, if he says primary, then don't answer idiopathic, you will answer antibody. In fact, this antibody has reduced the requirement of kidney biopsy for diagnosis of MGN. Majority of cases of MGN can be diagnosed simply on the basis of demonstration of anti-phospholipase A2, anti-PLA2 receptor antibody. This would be the one of the easier ways for identification, and then could be associations with infection. Hepatitis B and C, I told you hepatitis B, and then I spoke about C also, but C association that was asked primarily was MPGN. Then can be autoimmune. When I say autoimmune, it could be associated with, let me say, Graves' disease, Hashimoto's. So the surprising thing is that the damage that is seen in these autoimmune conditions can not only be limited to the thyroid gland, but can extend to the kidney as well. Then can be connective tissue disorders as well. So it could be like scleroderma, for example. And then most importantly, solid organ tumors. Must know information. The question says, which form of nephrotic syndrome would be associated with solid organ tumor, SOT, like lymphoma, or any other solid organ tumor described? Your answer would be given as MGN. The drugs to be remembered here would be D-penicillamine and captopril. Contrast this with the drugs that I was saying on the previous slide. I'll just show you the slide once again. I hope at least you remember lithium from that slide, pamidronate, and a street drug, heroin. I'll mention it that I'll show you that slide again. I talked about this street drug, heroin. Though I did not use the word street drug at that moment, pamidronate, lithium, these are three important causes for FSGS in contrast to the two causes drugs which I mentioned. And then you would also be able to, if it's a secondary variety and the antibody is not present, then you will have to do a kidney biopsy and a histopathological finding will be asked, which is subepithelial deposits with increasing matrix spike reaction. So you always read about spikes word. It's actually, this is a pathological description, but then they casually use the term like spikes projection, and subepithelial deposits are a feature of MGN, that is membranous glomerulopathy. When it comes to the questions on this topic, one of the most important one is what I have just said right on the top, the antibody one, and then these associations they are taught in pathology also should be remembered. We shall now be talking regarding the pediatric presentation of nephrotic syndrome, that is called as minimal chain disease. The alternative words that are used to describe it are nil lesion and lipoid nephrosis. First would be, why would this be occurring? The initial answer of yours would be idiopathic, but that would be too easy to answer in multiple choice questions for anybody. So the usual questions that would be asked for the why behind the development of minimal chain disease would be, one, NSAIDs are responsible. Another one would be that minimal chain disease is also a paraneoplastic manifestation that you see with Hodgkin's lymphoma. Just like you read about paraneoplastic manifestations of SIADH with lung cancer, or let me say Cushing syndrome manifestation, similarly in the same spirit, Hodgkin's lymphoma is associated with minimal chain disease. Now the case presentation would begin by describing a 4-year-old child who would be having puffy eyes. The mother noticed that when she was getting the child ready for school, the child was very lethargic and he or she was not able to open his eyes completely because of the periorbital edema. Now this periorbital edema can subsequently migrate downwards. So the same patient, in case it's a girl child, will have difficulty in urination because there would be a genital edema as well. And usually by evening, the child will also be having a bilateral pitting pedal edema, and therefore the child will not be able to wear his or her slippers. Some mothers might report that my child has become suddenly very heavy because in nephrotic syndrome there would be a reduction of oncotic pressure, swelling in the body, so that's why the weight gain component can be explained. The child might also be having breathlessness. Now the reason for this shortness of breath that might be experienced in some children is because of pleural effusion. And this pleural effusion that would be developing will be of the transudative variety. We always read about Light's criteria whenever pleural effusion comes into being. So in the subsequent part, when I talk about lungs, I will speak regarding Light's criteria as well. But at the moment, the only message is that this transudative bilateral pleural effusion, which will be causing a bilateral costophrenic angle blunting, is going to explain the shortness of breath. This would definitely be a massive effusion, pleural effusion, not a minimal effusion. There will also be ascites that would come up, and the ascites that is seen with nephrotic syndrome will be having a SAG value, that is serum albumin ascites gradient value less than 1.1. Now, I would like you to go through the liver section for this component, that the SAG value is not more than 1.1, it's actually less than 1.1, and the reasons for that is what I've explained in the ascites component. This ascites component will be contributing to increase in the abdominal girth of the child. So let me say it's a girl child and the parents brought a dress for the child, like a frock for the child. So they'll say that the dress is not fitting anymore. With these complaints, you will now be doing a workup of this patient. So let's look at what will be the workup findings for this particular child. And the good news is that the KFT will be normal. In minimal chain disease, as far as blood urea nitrogen and creatinine is concerned, most of the time the values will turn out to be normal. And this also tells you that usually there is no need for doing a kidney biopsy. I mean, it's only for academic reasons that I'm saying that if a kidney biopsy will be done, the findings will be light microscopy will be normal and electron microscopy will be showing a food process effacement. But in actuality, we will usually not be doing a kidney biopsy, and this would be a clinical diagnosis in the sense that I'll be subsequently evaluating the urine of this patient. Now, in the urine routine microscopic examination, we might be able to demonstrate lipiduria, that will be written as oval fat bodies, and I sensitized you to this oval fat bodies even in the earlier part of the discussion when I was talking about features of nephrotic syndrome. I will also be using a dipstick and would be checking for the magnitude of proteinuria, and usually the report will be either 3 plus or 4 plus. And if we get a 24-hour urine evaluation done, the value would be substantially increased. And similarly, in the spot sample, when I get the protein values checked, the values will be found to be increased. The magnitude of proteinuria would be more than 3.5 grams in a 24-hour period. In spot sample, more than 2 grams. Mainly the protein that will be present here will be low molecular weight protein. Because it is a low molecular weight protein, so the term that will be used will be selective proteinuria. When it comes to MGN, membranous glomerulopathy, which was discussed prior to this, we read in pathology non-selective proteinuria, because both low molecular weight and high molecular weight proteins would be lost. But when it comes to patients of minimal chain disease, it's mainly a selective proteinuria present. One of the important workup findings that will help you confirm the diagnosis would be C3 levels. C3 levels are usually elevated in nephritic, but when it comes to minimal chain disease, the values of C3 will be found to be normal. The fourth step is only for academic purpose that I'm writing before you. Otherwise, per se, we are usually not going to do it and start the treatment of the child with help of steroids. The finding that I want to state here is foot process effacement. And why am I rather emphasizing that is because you might be finding almost the same literature. I mean, foot process effacement word can also be written in focal segmental glomerulosclerosis. But over and above this, he might even mention regarding foot process detachment or foot process vacuolization. Here I just said the word effacement. Effacement means blunting. But when it comes to focal segmental glomerulosclerosis, there will be more severe damage present, and you will read like foot process obliteration. The words are effacement, which is relatively milder, and another term is obliteration, which is much more severe, which is encountered in focal segmental glomerulosclerosis. And now, once I made a diagnosis in this child, I'll be starting treatment, and the mainstay of treatment of this child would be steroids, prednisolone, and they have to be given to these patients for a total of 8 weeks. Initially, we'll be giving steroids daily, but then subsequently we'll shift it to alternate day steroids in this patient. Steroids obviously should not be discontinued suddenly because of the risk of triggering an Addisonian crisis, so you need to taper the dosage. If he says what will be given to this child for the periorbital edema component, then steroids will help in resolution of proteinuria. But to treat the edema component, to treat the periorbital edema component, ascites, as well as the pleural effusion component, it is spironolactone which is used, which is a potassium sparing diuretic. This is the preferred drug for management of edema / weight gain / ascites / pleural effusion that would be developing in these patients. And why am I not using thiazides is because of the risk of hypokalemia. So because this condition responds very well to steroids, therefore I'm going to call it steroid responsive nephrotic syndrome. Two special terms that I introduced here was one, selective proteinuria, foot process effacement, and a steroid responsive nephrotic syndrome, though you will also encounter in the subsequent slide me talking about steroid dependent and steroid resistant nephrotic syndrome as well. Now, if he says what is the treatment for this patient of steroid dependent nephrotic syndrome, then your answer will mainly be steroids. In fact, most of the cases initially when you will start steroids in children of minimal chain disease, you will notice that within few days itself the patient will start having a remission. The meaning of the word remission would be that if the urine of this child is evaluated by dipstick method, then the urine albumin value on dipstick will either come as trace or will come as nil. You need to have at least three consecutive nil reports to be present in a patient, and these consecutive reports are not of the same day. I repeat once again, to say that a child of minimal chain disease has gone into remission, you need to demonstrate total of 3 times in 3 consecutive early morning samples, and that means a bit of hard work on the part of both the mother and the nursing staff, that they have to ensure that the child does not urinate in the bed itself. Lots of time, I mean, children in their sleep, 4 or 5 year old children might pass urine due to nocturnal enuresis. They might pass urine in the bed itself. So we need to ensure 3 consecutive early morning samples which are to be preserved by the mother, and with dipstick you need to demonstrate that there is a remission occurring in the child. But in some cases, there can be the scenario where in spite of giving steroids, there could be presence of steroid dependency. And if you continue with the steroids in this case, then features of toxicity can also start developing. So let me just explain what the features of steroid toxicity are, though you know about it from nephrotic syndrome. One is that the mother of this child, you had told her that, ma'am, I want you to be under my follow-up for next 1 year consecutively. Though initially you had told her that we'll give steroids for only 2 months, but unfortunately the child turned out to be steroid dependent. So you said follow-up is required for 1 year. Now, this mother might think that the doctor is trying to make some extra money and because he's asking for extra consultations. So she did not follow up with me and she continued giving steroids to this child without tapering or without bringing the dose of the steroids to the lowest possible dose, which would have resulted in remission or would have resulted in reduction in the magnitude of proteinuria. Lots of time these parents might take their children to Ayush practitioners who might be giving medicines that again might be having very large dosages of steroids. So the problem is that if steroid dosage is not monitored, and the child should ideally be treated with the lowest possible dosage of steroids, which results in the minimum magnitude of proteinuria. If this does not happen and he continues to be on high dosage of steroid, then there could be cataract. You very well know this could be a posterior subcapsular cataract, and the child could be having difficulty at school because of the cataract component. Similarly, if it's a girl child, the mother will be saying that there would be facial hair in male distribution pattern. Similarly, steroid toxicity causes hypertension, so the child was suffering from headaches as well. Weakness, the play activity of the child has reduced, that is myopathy, and significant weight gain as well. And there was a question in the previous years where he had given a scenario like this, that a child who is a diagnosed case of nephrotic syndrome is on steroids for a very long duration without the monitoring of a doctor. Then what is the step to be taken by the doctor? Now, the same mother who earlier had refused to come to you for continuous follow-up, let me say after 1.5 years or 2 years, she came back to you again with the same child who is now unrecognizable because of the weight gain component. So what would you do in this particular case? Because steroids are causing problems. So I will have to taper the steroids, but the moment I taper the steroids, the proteinuria component will be coming back and the edema component will also be coming back. The puffiness of the eyes of the child will also be coming back. So here the textbook says that you must start the child on an alternative agent, that is a steroid sparing agent. And the drug that will be used in this condition would be cyclophosphamide. At least that is what Nelson says. In OPGAI, he has also mentioned regarding levamisole. So I am going to get queries because lots of time if you're reading OPGAI, it will say levamisole, but cyclophosphamide should be answered first for steroid. Listen to the words carefully. Cyclophosphamide should be answered for steroid dependent nephrotic syndrome with steroid toxicity. If he does not mention regarding steroid toxicity occurring in the patient, if he simply says, what is the treatment for steroid dependent nephrotic syndrome, your answer would be simply given as continue with the steroids in this particular case. In some cases, in spite of giving steroids, you could also be having is a possibility of relapse, and you would be having frequent relapser, you could be having infrequent relapser, and the definitions of this are again will be discussed shortly before you. But let's just simply try to first remember, what do you mean by the relapse in the patient? The meaning of the word relapse would be, as the name suggests, that the urine of the patient is again showing about 3+ or 4+ proteinuria, and in smaller children the cutoff to be used in a spot sample, like if you are gonna use a spot sample, it would be more than 40 milligram of protein per meter square of body surface area. The cutoff, you see, in adults we use 3.5, even in older children we use 3.5, but in smaller children the cutoff used is 40 milligram per meter square. And if you are able to demonstrate this on 3 consecutive days, earlier I was saying for 3 consecutive days it was nil protein. Now if there is gonna be on 3 consecutive days, and this is not 3 consecutive samples, this is 3 consecutive early morning urine samples that were preserved by the mother. She got up early and showed that the child did not wet his pants, etc. And this is a relapse which would be a cause of concern, and you can increase the dose of steroids for management of this patient. But in some cases, there can even be more problems in store for you, in a sense that earlier, whenever the child used to have a relapse, You used to increase the dose of steroids. Let me say initially the child was on 1 milligram per kilogram. You used to increase the dose of steroids to 2 milligram per kg, and the proteinuria used to resolve, the edema used to gradually start disappearing here. But now the mother is saying, sir, your medicines have become totally ineffective. Earlier, she was a non-compliant mother. She might have caused a toxicity. That was one possibility that I discussed with you. Another one is she is regular in her follow-up. She says, earlier doctor, your medicines used to work beautifully. In between, whenever you used to discontinue or decrease the dose of steroids, some bit of edema used to come. But when we used to come back to you, you used to write the same medicines in a higher dose, the edema used to disappear. But now nothing is working. In those circumstances, we will call it steroid resistant nephrotic syndrome. This should obviously be with high dosage steroids for at least 4 weeks. So the definition of steroid resistant nephrotic syndrome is, I would say, the most important one of all the definitions that I'm writing here before you. The meaning of the word steroid resistant nephrotic syndrome is absence of remission. Now I've told you the criteria for remission anyway, despite daily therapy. And when I say despite daily therapy of steroids, then you need to remember how much is the dose and for how long. I said two things. I said daily therapy of steroids, what is the dose being given and for how long. The dose that is being used is almost twice of what is used routinely, that is 2 milligram per kg, and this has been used for how many weeks? That is at least for 4 weeks. Now I agree that there can be some kind of a discrepancy because in some tables of pediatrics it might be given for 6 weeks also, but I think it's a range. Actually everything in medicine is always a range, so it's 4 to 6 weeks. Most physicians would like to keep a higher threshold for early detection. I wrote 4 weeks here because I would not like to waste another 2 weeks and then say, okay, your child is steroid resistant. I would like to start treatment right away, and the treatment in this particular case that would be started would be cyclosporin. So before I summarize the facts, I want you to get the definitions right. The definition for steroid resistant has been asked in the exam, so I'll say this once again. High dose steroids, that's 2x of the normal dose for 4 to 6 weeks. First answer is 4 weeks, and still there is an absence of remission in the patient. That's when cyclosporin is to be started in the child, or tacrolimus, and the diuretics will anyway continue spironolactone. We usually avoid giving thiazide diuretics to these patients. The summary can be remembered like this. If you read a question with respect to steroid responsive nephrotic syndrome, or if you read a question with respect to steroid dependent nephrotic syndrome, then in both circumstances the answer of yours would be given as steroids. That's not an issue and you would be able to answer this easily. However, let me say, he mentions that the patient is having steroid dependent nephrotic syndrome and is giving features of steroid toxicity also, ranging from cataract to hypertension to hirsutism. Then your answer in this case will change, and you will be answering this as cyclophosphamide, the same molecule which is notorious for causing hemorrhagic cystitis. But if he uses the following term, that is SRNS, that is steroid resistant nephrotic syndrome, then your answer would be changing once again, and this time it would be cyclosporin. If that is not in the options, then your answer would be given as tacrolimus for the patient. We will also make a table here for the various varieties of nephrotic syndrome that I've discussed before you. I'll be describing the congenital nephrotic syndrome after I've done with this slide. So let's look at the age groups that we have talked about. We have talked about nephrotic with respect to adult versus geriatric age group versus that in pediatric. And when it comes to neonatal presentation, then you call it the Finnish variety of nephrotic syndrome. That would be common in children in the northern part of Europe. So let's write the age groups here because that would help you in identification of these subtypes clinically. This would be a child versus neonate. The neonate is totally, I would say, the neonate is having extensive amount of edema present. So in fact, for the Finnish variety, though I'm tempted to talk about nephrin and podocin, I will do that on my subsequent slide. But at the moment, I just want to say that the presentation of neonatal version would be a non-immunogenic hydrospitalis. There would be extensive swelling in whole body of the child. And if you are supposed to keep this child alive, you will have to give IV albumin infusions to this child, and they are expensive. So, I mean, when you tell the parents that we will have to keep your child alive by giving albumin infusions, they will say, okay, sir, we'll afford it. How long do you need to give it? And when you tell them lifelong, and they're like, sir, are you serious? I mean, you were telling me that my child's body proteins are being lost in the urine because the kidney is losing large amount of albumin, and you need to replenish it for whole life. I mean, how's that possible? So one, because of the lack of practical solution. I mean, the only way to treat the Finnish variety is to go in for a kidney transplantation, and you can't put an adult's kidney in a child. No, it's not that you can put father or mother's kidney in the child and the child would be fine. Though the parents will say, okay, we're ready to donate one kidney. You have to go in for an age matched donation here. That is another child of the same age group, neonate, right, who's dying because of any of the reasons. If his parents agree for a kidney donation, that's when that's the only way for possible for survival in this particular case. There are two varieties of it, NPHS 1 and 2. At the moment, though the details of this will follow up in the subsequent slide, from the exam perspective, they've asked which one is having a poorer prognosis. Then it is NPHS2 variety, NPHS2 gene defect, which has a poorer prognosis. For minimal chain disease, there will be a special finding that would be given whenever he's describing the kidney biopsy findings, that is IgM deposits present. And the second one would be that there would be a food process effacement. Effacement would mean blunting present. Now, in contrast with membranous glomerulopathy, where I talked about anti-phospholipid 2 receptor antibody present, the finding that would be given would be mainly that of subepithelial deposits. You will read about subepithelial deposits in PSGN also, but the additional term that would be present here would be presence of spikes, which is not present in post-streptococcal glomerulonephritis. Though in PSGN, you can obviously go in for immunofluorescence study that will show a starry sky kidney as well. When it comes to focal segmental glomerulosclerosis, he will talk about adult. He will talk about him having even hypertension. In FSGS, you not only have is a nephrotic range proteinuria, but concomitant hypertension can be present as well. Why hypertension? Because I said glomerulosclerosis. If I say sclerosis, that means fibrosis in the kidney. So GFR is less. Therefore, there's a high renin hypertension. And the biopsy of this patient is showing hyaline deposits. And then there are changes in the food processes also. Lots of time these changes in the food processes might be written as effacement as well. So effacement is common between the two, but one word that I'm writing subsequently before you is that these patients could also be multiple choice question, could also be using terms like effacement word is common between both of them, but one word that will be different will be effacement and obliteration. In minimal chain disease, I'm saying only effacement. But with FSGS, I'm saying effacement and even obliteration, or he might say vacuolization, or he might say detachment. I did not use the word detachment for the inferior scenario. This is an important table, guys. I would like you to make a table like this for all the conditions of the kidney by yourself, where all the light microscopy findings and then electron microscopy findings and immunofluorescence findings are given at a single page, so that every time they give you a histopathological link up, you are able to answer this. Similarly, the management perspective for SDNS with toxicity and steroid-resistant nephrotic syndrome is to be remembered, including the definition where the steroids are given at 2x of the traditional dose for a duration of 4 weeks, and still the proteinuria part was not resolving. Now we describe a neonate who has been born with extensive amount of swelling around his body. This is because of the proteinuria component, and there are two reasons why this could be happening. One of them could be a defect in NPHS1 gene or NPHS2 gene. And the gene defect results in defective proteins. The proteins which are defective is nephrin and podocin. To remember it, all I can say is that alphabet N will come before P. So N comes before, so NPHS could be, 1, and then NPHS2, that is 2 coming up. So second alphabet to be taken care of, that is podocin. And what is the importance of this nephrin and podocin is that they help in formation of filtration slits. You're aware that in the kidney you have filtration slits, and the size of these will limit which proteins can leak. Like albumin can come in urine of a normal person also. The amount of albumin in a urine of a normal person will be less than 30 milligram on a daily basis. But fibrinogen never comes. Why? Fibrinogen is a large molecular weight protein, and the size is also bigger, as a result of which it will not be able to cross the filtration slit. The proteins which are going to be helping in formation of the filtration slit is nephrin and podocin, and if this filtration slits are not working properly, then the proteins can be leaking much more than normal. Much more than normal does not mean here that fibrinogen would be leaking. It is albumin that would be leaking much more than what it normally should. The presentation would be called as non-immunogenic, because if I say immunogenic heterospitalis, that can be Rh incompatibility. You see, antibodies found in a Rh negative lady, they could be damaging the RBCs of the child, the fetus that she is carrying, and if the fetus RBCs are destroyed, the fetus will develop anemia. Anemia will cause heart failure, and therefore the whole body of the baby will swell up. So we call it immunogenic hydrospitalis. But non-immunogenic is what you read one in hematology. One condition in hematology which I would like to mention is with alpha thalassemia. When you read about hemoglobin BARTs, that's where you read about non-immunogenic hydrospitalis, and the second one is what we're discussing at the moment, because the whole body of the child would be swollen. So anasarca with a foamy urine. Foamy urine is one of the terms that will be given in MCQs of the clinical variety to describe proteinuria. I can just say, like, when you pour beer into a glass, then you will notice foam on the top of the glass with respect to beer. A similar kind of a description might be given by a patient of nephrotic syndrome, or in this case maybe the mother who might be collecting the urine sample of the child that you had instructed her to do. When you will check the 24-hour urinary protein, then the magnitude of proteinuria in this particular case would not be answered as more than 3.5 grams in a 24-hour period, or more than 2 grams per gram of urinary creatinine. For neonatal age group, the cutoff to be remembered is 40 milligram per meter square of body surface area. And again, the problem is, how do you collect 24-hour urine in a child? I mean, newborn baby will urinate anytime you want, no? So there are special bags available which can be stuck onto the genitals of the child, and you can collect the 24-hour urine. But again, the problem is those bags can leak, or they can come off, or the mother may not be comfortable putting those bags on. Saying stick on bags that can be stuck to the genitals of the child, but they can come off also. So we have to rely on a spot sample. Babies urinating, difficult to coordinate the activities, urinating, need to collect some sample, and the magnitude of proteinuria in this case would be 2 to 3 milligram of albumin per milligram of UC. UC here means urinary creatinine. So the values are from neonatal perspective. You are supposed to remember mainly the adult values that I taught you for 2 grams per gram of urinary creatinine, but these are neonatal values which should be remembered. And a lot of these children usually die because of infection. Most of them actually, when the moment they get out of ICU and they're having a problem with their filtration slits of the kidney, so even antibodies can be lost via the urine of these patients. So even gamma globulin fraction in these patients is reduced. So most of these parents, because of cost issues, will say, okay sir, we want you to discharge the child. We cannot afford IV albumin injections on such a long-term basis. So when you send the child home, they'll take him back home, in the village, and most of the time the child will develop a pneumonia, or will develop a UTI, or will develop a sepsis, and will unfortunately expire. Now the next slide I'll be utilizing to tell you definitions of a frequent relapser versus an infrequent relapser. So one, you can just put guidelines here, that is 6 months and then over 12 months. And the data to be remembered is like this. If a patient is having 1 relapse in 6 months, or is rather having 1 to 3 relapses in a 12-month period, then I'm gonna be calling this child as having an infrequent relapse. The definition of relapse, I told you that the proteinuria is back once again, at least present 3 to 4 plus, present for 3 consecutive days. Then you can put numbers like this, like suppose there are 2 relapses in 6 months, or there are 4 relapses in a 12-month period, then you are gonna call it a frequent relapser. You can see that in this particular case, the examiner can play around with the numbers here. I said at the minimum that you should be doing is at least 1 relapse in 6-month period and 2 relapses in a 6-month period. But he can make it a 12-month period as well, which is why I have decided to speak about it. Though the definition of steroid resistant is what I've already sensitized you to, that would be failure to achieve complete remission by 4 weeks in spite of using 2 milligrams per kilogram on a daily basis. We will now compare this information of nephrotic with nephritic, that is glomerulonephritis. And whenever glomerulonephritis as a word comes up, the first thing in our mind is PSGN, that is post streptococcal glomerulonephritis. But I want you to remember that the leading cause of glomerulonephritis is not to be answered as PSGN. The number one reason for development of why in a patient would you be having is glomerulonephritis, where you have a hematuria with hypertension, is Burgess disease, which would also be referred in a lot of books as immunoglobulin A nephropathy. This disease would be having damage mainly to the mesangium of the kidney, and the RBC leakage will mostly be microscopic hematuria. Though they can upgrade from microscopic to gross hematuria, and I will teach you how they upgrade from microscopic to gross. But before that, before we get into the discussion of Burgess disease, which is the leading cause of glomerulonephritis, also let us have a look at how post-streptococcal glomerulonephritis, which occurs after infection with Streptococcus pyogenes, that is group A Streptococcus, evolves in a patient. We have certain strains of this particular bacteria that can affect the heart. So we always read about group A beta hemolytic streptococcus being responsible for rheumatic fever, and then we read about the same organism responsible for kidney involvement as well. The question in everybody's mind is therefore, how is it possible that the same bacteria is causing two different diseases, fundamentally different diseases, because rheumatic fever is type 2 hypersensitivity and post-streptococcal glomerulonephritis is type 3 hypersensitivity. So basically I want to tell you that some of the strains of this particular bacteria are called as nephritogenic strains. These nephritogenic strains result in glomerulonephritis manifestation, and there are some of them which contribute to mainly a rheumatic fever presentation. Now, what is present on the surface of this bacteria which results in formation of production of antibodies and then immune complexes? Because I told you, PSGS is an example of type 3 hypersensitivity reaction. So what is present on the bacteria which is causing immune complex production is the special name of this antigen, that is SPEB, that is streptococcal pyrogenic exotoxin B. I repeat again, SPEB is the name of the special antigen on the surface of this bacteria which results in antibody production, which combines with this antibody to produce immune complexes, and these immune complexes then get distributed across the entire glomerulus. And if you do a immunofluorescence study in this patient, then you always get is a presentation of starry sky kidney. I don't think that he'll get into the numbers here for these nephritogenic strains, but you will notice that the ones which are shown at the moment and are in single digit, like 1, 2, 3, 4, except for 25, you neglect 25 for a second, the ones which are in single digit, they are first causing a pharyngitis in the patient. But the ones which are in double digit, like 47, 49, 50, 55, 60, the ones in double digit are causing pyoderma, that is impetigo in a patient. Yes, the same disease which the dermatologist will describe as honey crust lesions. I mean, in derma, usually, especially FMJ exam, they always give this image of honey crust lesions in a child, especially in rainy season when the humidity is going to be high, the child is going to be sweating, impetigo incidence increases. If a child is having impetigo or is having a sore throat by this bacteria, both of these can cause immune complex production that can damage the glomerulus. The time that it takes for the kidney manifestations to develop, in case it is going to be pharyngitis, is relatively lesser, about 3 weeks. But if it is going to be a pyoderma, if the patient is having pyoderma, let me say in July, then the manifestations of impetigo will usually occur after middle of August. That is going to be approximately 6 weeks. So you can see almost a doubling happening. I mean, double of 1 is 2 and the double of 3 is going to be 6. I repeat once again, if it's pharyngitis, let me say in July, patient had pharyngitis, then in the same month only kidney involvement will be seen. But if it is going to be a skin involvement, then the manifestations will take at least 6 weeks to appear. So it's the next month that the manifestations will occur. And what will be the manifestations? The manifestations would be standard. I know the image looks a little ugly, but I just wanted to give you a semblance of what you mean by the word cola color urine. This is hematuria. The RBCs will get destroyed and the hemoglobin will not be red in color. It would be brownish black. So that's like cola colored urine. So a mother will maybe be carrying a urine sample and she might say apologetically, or sometimes, they just block that urine bottle in front of you and say, sir, see the color of the urine of the child. If it is a freshly passed urine sample, if it is a freshly passed urine sample, then RBCs will not burst immediately, no. Then you might read about the word smoky urine. But after few minutes, if you keep this smoky urine in front of you for a while, then it will change color and it would be cola color. Mainly because it is glomerulonephritis. Therefore, there is going to be RAS system activation. And because the glomerular flow is affected, there is a RAS system activation, there would be hypertension in the patient. This hypertension can be so bad that it can even cause this child to lose consciousness. So I have a very anxious mother who's telling me, sir, my child has become suddenly unconscious. Lots of time they may even fail to notice that the child's urine, maybe 10-year-old child, he'll go to the bathroom by himself. Child did not notice the urine color is changing. He was complaining of headache and the child suddenly became unconscious. In any unconscious patient, when you check the BP, in any unconscious patient, you are supposed to check blood sugar, you will check the vitals of the patient, and when you check the BP of this child, it was, let me say, 170 by 110. And you are thinking to yourself, 10-year-old kid with a BP of 170 by 110, you ask the mother, did the child have any problems with respect to blood pressure? and she's looking at you and saying, sir, blood pressure problem. I mean, hypertension in India, they call it blood pressure problem. No, mother is saying, sir, blood pressure problem is seen in adults. Why would my child have hypertension issues? So you're wondering, I mean, child 10 years of age, unconscious, very high BP. So you decided, okay, let me get the kidneys of this patient evaluated. Let me get a urine sample of this patient tested, and that's when you found he was having a smoky urine present. In some cases, there might even be breathlessness experienced by the child. This can contribute to even a development of left ventricular failure that will cause pulmonary edema, that will cause shortness of breath in the child. So there is a possibility that the post-streptococcal glomerulonephritis diagnosis may be missed because you might be thinking child is having pulmonary edema due to cardiogenic reasons, or he's having an encephalopathy, maybe because of some, I mean, the word is unconsciousness in a child, no? So he could be having it due to CNS infection. Lots of time, you will realize by the second day that the reason either the child is having this pulmonary edema or is having an encephalopathy is because of high blood pressure. And this high blood pressure is why present? Because it is the kidneys getting involved. So you need to join the dots together so that you are able to come to the final diagnosis of this patient. And lots of time diagnosis will be made pretty late, to the level that the child will even develop features of acute kidney injury, where child might develop oliguria and uremia as well. And uremia can cause even chest pain, uremic pericarditis. So PSGN, guys, is gonna be a question that would be given to in your exam. In your exam, he will make it easier when he will write that this child previously had a skin infection or had a sore throat. But in real clinical practice, lots of time, we are under so much of stress handling so many patients that we usually forget to ask about past medical history, and we are fumbling for why is the child unconscious or why the child landed up in heart failure. The common thing was hypertension was documented, but why is this hypertension present is because of an inflammatory immune complex mediated damage to the kidney. In this condition, if he gives you this past medical history of impetigo and pharyngitis, things will become relatively easier for you. If not, he might even mention regarding antibodies. One of the antibodies that will usually be given to as an aid for your diagnosis, obviously ASO antibody is one of them, right? I mean, no issues with that. But another antibody that you might encounter is anti-DNA ACE antibody. So the point is our anti-hyaluronidase antibody. In fact, I can just jot down the names here once again. ASO antibody is mainly for rheumatic fever. So if you read a MCQ where there's gonna be retrospective history given, and then you read about anti-hyaluronidase, or you read about anti-DNA ACE antibody, that is when you have to give credibility to PSGN as a diagnosis. And there is also possibility that he might give you immunofluorescence study. I mean, the examiner will try to make it relatively easier for you. If he gives you immunofluorescence study of a starry sky kidney, then it is highly unlikely that you will ever miss it. But on comparison basis, I want to say that in nephritic syndrome, you are gonna have is a presentation of mainly hypertension with hematuria. The hypertension can obviously cause these complications, and there would be a subnephrotic proteinuria that would be between 1 to 3 grams in a 24-hour period. Now, you very well know that the overall leading cause of development of hematuria is kidney stones, but from a medicine exam perspective, whenever they give you a question related to hematuria, there can be two possibilities. In one of them, he might be mentioning that the person suffered from a URTI, upper respiratory tract infection, and then as little as 48 hours later, the patient ended up with development of a cola-colored urine. If you're going to check out the C3 values in this patient, it will be normal. Most of the time, the BP values in the patient will be normal. And even when you calculate the eGFR of the patient, estimated GFR by any of the formulas, even the GFR of the patient would be normal. This is going to be the usual presentation with respect to Burgess disease, which is also called as immunoglobulin A nephropathy. But if you read a question in which he can be describing a skin infection, that would be impetigo. Or instead of impetigo, he might be mentioning pharyngitis also. So you can see why in the textbook he will write the word synpharyngitic. I mean, what I'm describing before you at the moment, the term that could be described as synpharyngitic hematuria. And there are two differential diagnoses of synpharyngitic hematuria. The reasons are as follows. If he says synpharyngitic, you obviously need to consider Burgess disease, that is one. But let me just write this again, synpharyngitic. I want you to be very clear about the fact that the second differential for this person would be presentation of PSGN, where obviously the time that would be taken would be a little different. Here, the duration that will be given in the question with respect to the development of hematuria will be in weeks. On the right hand side, I said as little as 48 hours. Now I'm talking about weeks, at least 1 week versus 2 weeks, as I told you on the previous slide. Or like, I'll just go back here. I told you in PSTN, if it is empatico, it will take approximately 6 weeks upper limit. Pharyngitis, it will take 3 weeks, doubling of both mathematical values, but at least it was in weeks, no? Then C3 values in the patient would be lesser. Blood pressure would always be elevated, and he will talk about presence of those special antibodies, the names that I was saying in the previous slide, like anti-hyaluronidase antibody or DNase antibody. This is gonna be PSGN, that is post-streptococcal glomerulonephritis. So in medicine MCQs, most of the time the question would revolve around the differentiation between the two scenarios, and don't straight away comment on PSGN as an answer. I shall now be discussing methods which are useful for calculation of glomerular filtration rate in a patient from both the pediatric perspective and general medicine perspective. The question in the exam said, and this is the INI set question, calculate the eGFR of a boy aged 4 years, weight is 14. Weight is a dummy information because the GFR in a child is not dependent on weight. It is rather dependent on the height. Height would indirectly correlate with the muscle mass. Serum creatinine is 1 and the BUN value is also given, but you don't need to take into consideration even the BUN value in the mathematical formula. The formula goes like this: eGFR in a child would be calculated as kappa into the height of a child divided by serum creatinine. Kappa is a constant value. The reference for this would be from OP Ghai, the textbook of pediatrics. The range is between 0.41 to 0.43. So if I just take an average of 0.42, multiply this by the height of the child, which is 100 centimeter, divide this by serum creatinine, you can see what I was saying earlier also, that most of these mathematical questions that come would be a one-step multiplication or a one-step division. No rocket science required here. The answer for this would be option number B, that is 40. And on my subsequent slide, I will demonstrate before you the Cockcroft-Gault formula. But before I do that, I also want to bring to your notice the fact that Cockcroft-Gault formula is not as accurate as the ones on the slide at the moment. If the question simply says which of the following is the best way to calculate the estimated GFR, then from physiology perspective, you obviously read about inulin clearance. But here we are talking about methods which are better than inulin clearance. That is, the best one would be answered by you as CKD EPI equation. When I was teaching your senior batches, the previous editions of Harrison used to talk about MDRD, that is modification of diet in renal disease formula. MDRD is modification of diet in renal disease formula. But currently the textbook mentions CKD EPI to be superior to all other methods of calculation. Now let's focus on the numerical based question where we will be using Cockcroft-Gault formula. He will specifically mention calculate the eGFR by Cockcroft-Gault formula. So let me write down the formula before you. This would be 140 minus age. This is to be multiplied by the weight of the individual, and the denominator in this case is 72 into serum creatinine. Let us put in the values for this formula now. It's a 40-year-old female during, she's a known case of type 2 diabetes mellitus, and during annual medical checkup, her weight was found to be 40 kg. I mean, usually we find that Indian patients can be malnourished as well. Though she's a diabetic patient, she's not having a weight gain, rather she's only 40 kgs. And serum creatinine of the patient is 1. So everything looks fine at the moment. Let's put in the formula now. The mathematical values would come like this. I'm going to subtract from 140 the age of the patient, that is 40. Multiply this by weight. The weight of the patient is 40 again. And 72 divided by 1. Now when you look at the mathematical inputs here, it would be about 140 minus 40 would be 100. I'm teaching you mathematics here. This would be 4000 because I multiply 100 by 40. So this is going to be 100 into 40 would be 4000 divided by 72. And shockingly, the value of the GFR of the patient is coming up to be 55. You can once see that Cockcroft-Gault formula tends to usually underestimate the GFR of the patient, especially if the weight of the patient is on the lower side. This is the disadvantage to this formula, especially for patients like average weight of Indian patient would be like 60-65. But if you're having a patient who's having less muscle mass and he's from rural India, or relatively I would say a patient with a low body mass index, then this formula tends to underestimate. In fact, whenever he talks about a female patient in Cockcroft-Gault formula, then there's an addition that I want to tell you over and above this, that because females have lesser muscle mass, so this formula is valid for a male patient. If it is a female patient, you have to multiply this further by 85, 0.85. So if I take up mathematically here 0.8 of 55, this will turn out to be even lower, that is about 40 ml. Now, there are two things which I want to bring to your notice from the answer that I gave you. First of all, serum creatinine is not a very reliable method for detection of damage to the kidney. Especially when it comes to acute kidney injury, serum creatinine takes time to rise. So when I will be discussing the acute kidney injury network criteria before you, you will notice that serum creatinine will be one of the components, but not the only one, because it takes some time to rise. And we nowadays have novel biomarkers that can pick up the damage to the kidney relatively early. Second, I also want to bring to your notice that if you are having a patient whose serum creatinine is 1, the first impression in your mind would be, okay, everything is fine, but it is a diabetic patient, right? So do not, on the basis of serum creatinine, tell a diabetic patient that everything is fine, because they might be having a diabetic nephropathy and it could be picked up early on the basis of albumin creatinine ratio. We can take a spot sample of urine, and in the spot sample we can check for the albumin concentration divided by the creatinine present in the urine sample. In earlier times we used to read the word microalbuminuria, but nowadays the screening test for diabetic nephropathy would be urinary albumin creatinine ratio, or I can say casually albumin excretion rate. Do we have albumin in the urine of a normal person? Yes, that's less than 30 milligram in a day. If it's much more than that, 30 going up to 300, up to 10x of normal, it indicates that in a diabetic patient the damage has already occurred. I've spoken about this even in the endocrinology section of this rapid revision as well. There are two messages that I want to give you from this particular mathematical discussion that I've had. Point number one, Cockrodt-Gault formula is not very accurate. When I was a student, I used to read very accurate method. It's not accurate. Why? Because of the fact that it can underestimate the GFR of a patient with respect to an underweight patient. That's one message. Message number two is that serum creatinine can give you a false sense of security. I mean, do not only on the basis of blood urine nitrogen creatinine tell a person that okay, your kidneys are normal. If you're having a risk factor like diabetes is a risk factor for development of CKD, must use these statistical formulas to actually calculate the GFR. Out of the three methods that I've taught you, Cockrodt-Gault formula, MDRD and CKD EPI equation, CKD EPI equation is the most superior one. It not only takes into consideration aspects like female gender, it also takes into consideration race of a patient. Like I would say African patients would be more muscular than us, they would be taller than us. So this formula is relatively more accurate, and I don't think so that they'll give you a complicated mathematical formula ever in the exam. What they've done is only this one-step calculation in the INISET one, though you should be ready in case they decided to ask you the Cockrodt-Gault formula as well. The disadvantages what I've highlighted. Now, my objective would be to speak regarding chronic kidney disease or CKD, and the leading cause of this happens to be diabetic nephropathy. They can also ask you regarding the histopathological findings of diabetic nephropathy, which would be the most common one would be diffuse glomerulosclerosis and characteristic would be nodular. I'm not writing that because that's taught even in pathology. And if he says what is the leading cause of death in these patients, why would a CKD patient die? I can give example of our former minister in the BJP government, Sushma Swaraj madam. She was a known case of diabetes. She ended up with CKD. She underwent a kidney transplantation as well. But unfortunately, Sushma Swaraj ma'am, she died because she was a big anti-reval MI, secondary to the inflammatory state that occurs in these patients of CKD. I mean, what I'm saying is not only patients who are undergoing a hemodialysis are predisposed to increased chances of dying due to cardiovascular disease, but CKD per se itself is a inflammatory condition, pro-inflammatory condition that predisposes to higher chances of MI and stroke in these patients. Then as far as the classification of CKD is concerned, they are currently talking about grades, and you start from 90. You start from 90, then you downgrade. You downgrade here by a value of 30, that is about 60 to 89, that would be grade 2. Then subsequently you again have to decrease by 30, but what they've done is they have subdivided this into 15 decrement, that is from 45 to 59, that's going up to 60, right? And then another decrease, and once you go into G4, that is when majorly complications will start occurring. I mean, at this point of time, potassium will be increasing, the values of phosphate will be substantially increased, and you could be having complications like uremic pericarditis as well. The term end-stage renal disease is replaced by the word kidney failure. I mean, when I was a student your age, I used to study, I mean, this word is still valid, but what I'm saying is we used to read ESRD is defined as, we used to answer less than 15 ml, but in this classification you can see the word used is kidney failure, which is I would say a relatively a non-specific term. You will also notice that in this table he has also talked about albuminuria in the patient as A1, A2 and A3. The values to be remembered are less than 30 milligram per gram. In the denominator it is not per day, it is gram of urinary creatinine. If it is 30 to 300, we call it A2. If it's more than this, we call it A3. So lots of time you might be seeing on the case file written like G3A2 or G3A3. I mean, traditionally when we read this G3A3, we are talking about, from the OBGYN perspective, gravida 3, abortion 3, something like that, right? But in this case, it's the grade. I mean, we are not talking about any obstetric formula here. We are talking about the grades of CKD per se, and the values, mathematical ones, I would suggest you to practice once. That would be more than 90, then it's going to be 60 to 89, then it's going to be substantially reduced by another 30, but you have to downgrade this by 15 for G3A and G3B. Then would be decrements by 15 again, that is from 30 you're downgrading again by 15, that would be 15 to 29. I mean, G4 is the time when you need to be very clearly in clear words telling the patient that, sir, we need to take a call on either planning a hemodialysis or we need to go for a kidney transplantation. A kidney transplantation is any day superior as compared to hemodialysis. One, hemodialysis has exerted atherosclerosis. Secondly, hemodialysis patients, they would be having to make multiple visits to the hospital because hemodialysis usually is done 3 times per week. One session of hemodialysis would be approximately 4 hours. So patient will have to invest at least 12 hours per week coming to a hospital. That's only the in-hospital stay. The time that it will take for traveling would definitely be much more than that. So lots of time. I mean, the quality of life becomes poor with hemodialysis, especially, I mean, in a big city like Delhi, where maybe you have so many hospitals, it may not look so obvious for you. But suppose you go 100 kilometers away from Delhi with lesser medical facilities, patients have to really travel long distances so that they can come in for hemodialysis. So kidney transplantation would be a one-time solution, plus we'll be having lesser complications, in a sense that, yep, I mean, opportunistic infections can definitely occur post-kidney transplantation because the patient will be on immunosuppressive drugs. So I'm going to tell you subsequently what are the common opportunistic infections that will develop. But at the moment, my objective over the previous 3 slides was mathematical. That is, one, I taught you about the pediatric EGFR calculation, Cockrodt-Gault formula, I taught you the limitation of serum creatinine, and then I taught you about these decrements that you need to remember for the various grades of CKD in a patient. Now, subsequently, we'll talk about some important aspects, and the first one that I'm saying is widely debated with respect to what should be the target blood pressure in a CKD patient. I've given the Harrison of the 21st edition of Harrison. He says that the target BP should be less than 130 by 80 millimeter of mercury. I've been saying this even in the previous version of the app also. But you see, some European guidelines are mentioning 140. Some guidelines are even mentioning 120 by 80. This is what Harrison says. So I think this is what is recommended for the exam. Then these patients can be having a edema component also. So what can you give for management of pedal edema of these patients is one, thiazides. But another diuretic that can be used in this patient is metazolone. Metazolone can be specially used, especially if the eGFR of the patient is on the lower side. I mean, if the GFR decreases, then the routine diuretics either don't work or they do not produce good results. But when it comes to metazolone, it can be used even when the GFR of the patient is less than 30. That was G4. G4 is what I'm talking about, where metazolone can be used. And once he goes into kidney failure, that is the older term ESRD, then alpha blockers like prazosin can also be used. You see, initially we are anyway going to use ACE inhibitor. If it's going to be G1, G2, I can use ACE inhibitors. But you know the side effect of ACE inhibitors is hyperkalemia. So if I am having a patient who is G4, G5 and potassium is very high, I can't use ACE inhibitor. Then I'm limited by the hyperkalemia component, and I can then use calcium channel blocker. But suppose I'm giving CCB maximum dose, I'm giving metazolone maximum dose, and still the BP is not controlled, then I can be adding prazosin. I repeat again, let me say G4, G5, very high potassium. I decided, okay, I'll discontinue ACE inhibitor. The BP will spike. So I used CCB, I used metazolone. But in spite of that, if the BP is not controlled, I can be adding alpha blockers in the patient as well. And this concept has been asked in NEET PG in the previous years. Then, as I said, the problem with the ACE inhibitors is that with the usage of them, you might have is a drop in eGFR. So, especially when you are handling patients of G2, G3, you should be careful regarding the fall on GFR. If it happens, you should discontinue this, and especially with potassium, I've told you that you have to discontinue ACE inhibitors. And meanwhile, you also can give caliuretics to the patient. The caliuretics that you can give is the traditional furosemide, and along with that you can add metazolone, and you can also give novel potassium binding agents, that is patiromer. When I was a student at your age, I used to study regarding mainly sodium polystyrene sulfonate for management of hyperkalemia, chronic one I'm talking about, but currently they especially mention regarding patiromer. And in the electrolyte component also, I have spoken about patiromer as a novel agent for management of hyperkalemia. The best approach is stop the drug. But if you stop that, then the BP will spike, because kidney damage is a high renin hypertension. You are removing the main weapon that you had to fight against the increased renin and the upgraded RAS system. So if I want to continue ACE inhibitors, it has to be under a very careful watch, and I can try to first control the potassium values. I repeat once again, a patient of CKD is having elevated potassium. You are in a catch-22 situation. If you discontinue ACE inhibitor, BP is gonna rise dramatically. You will use alternative drugs also, but you're removing the main weapon. You see, CCBs will only dilate the blood vessels. No, they're not gonna utilize the RAS system. So when you remove your main weapon that was deployed, you are a little vulnerable. That's what I mean by the word catch-22 situation. So I said, I will take a chance initially, and I will try to lower the potassium. The approaches for lowering of potassium can be furosemide and metazolone along with patiromer, but in spite of usage of them, potassium is still high. Then I don't want to take a chance. I've discontinued ACE inhibitor in the patient. Another problem from the cardiovascular perspective that can develop in these patients is uremic pericarditis. So you could be having hypertension, hyperkalemia, metabolic acidosis occurring in these patients. You can manage it medically. You see, if I say the word medically resistant metabolic acidosis in a patient of CKD, hyperkalemia refractory to medical therapy, hypertension not responding to medical therapy, then I might have to do a hemodialysis in the patient. But if he says absolute indication for hemodialysis, the word is absolute indication for hemodialysis, then the answer should be given as uremic pericarditis. Urea will not only contribute to even uremic encephalopathy, but it will contribute to uremic pericarditis also. And suppose you get a question in which uremic pericarditis and uremic encephalopathy both are given, and he asks you to select one as absolute indication, don't select uremic encephalopathy. Your first primary answer for doing a hemodialysis would be uremic pericarditis. Another problem that will crop up in these patients would be elevated values of phosphate in all patients of CKD, because there is a defective excretion. So phosphate values will crop up. They will rise. Calcium white is lesser, that is understandable. I mean, the reason for decrease in the calcium of these patients is that the synthesis of vitamin D3 by the kidney would be lesser. You see, kidney produces 125 dihydroxycholecalciferol. If the kidney will not work properly, 1-alpha hydroxylase is present in the tubules of the kidney, in the PCT cells. So if the kidney parenchyma is damaged, 1-alpha hydroxylase is not working, vitamin D3 is less, calcium is less. But the reason for increase in phosphate would be a defective excretion. I mean, it's filtered by the kidney. Here the GFR is less, so phosphate values will rise. One, because of this low values of calcium, these patients will also start having is an elevated value of PTH. So all patients of CKD will be having secondary hyperparathyroidism. This is itself a question. What is the number one cause of secondary hyperparathyroidism? Answer is the topic that we are studying, that is chronic kidney disease is responsible for it. If I change this to what is the leading cause of primary hyperparathyroidism, then your answer would be given as parathyroid adenoma. And most of the time, there are 4 parathyroid glands obviously. Most of the time it would be an inferior parathyroid gland that would be harboring adenoma. It's not that it will always occur in inferior, but that's what is usually encountered. So primary is parathyroid adenoma. We can be doing a special scan in this case, that is SYSTA-MAVI scan. But in secondary hyperparathyroidism, it is going to be deficiency of calcium and elevated phosphate. Now, what is done to handle this elevated phosphate is again a special interest of the examiner. So we need to give phosphate binders to the patient, and phosphate, because it can be absorbed from the diet, so we therefore need to give phosphate binders with meals. The phosphate binders that we can be using are calcium acetate and calcium carbonate. The problem with these molecules is that they can cause a disproportionate rise of calcium. Remember, initially calcium value was lesser in the patient. The calcium values can become normal with the usage of these molecules, and then can become much higher as well. And once the calcium values increase, then they can contribute to calcification of blood vessels in these patients. Again, a very catch-22 situation, I can say, that if you don't use it, the patient is anyway having azotomic osteodystrophy, the bones will become weaker, calcium values are lesser. And if you use calcium acetate, the values will become normal, and then will start rising also, and that can cause calcification of blood vessels. So you don't treat, you have a problem, and you do a over treatment, you still have a problem. So alternative phosphate binder which we can use and does not have the disadvantage of causing this calcification of blood vessels is sevelamer and then lanthanum carbonate. If they ask you which is the preferred phosphate binder, and calcium acetate, calcium carbonate, all of these are given, then the first preference should be answered as sevelamer and lanthanum carbonate. Why? Because they would be having lesser amount of side effects in the patient with respect to calcification of blood vessels. Another drug, a new drug which is given in the current edition of Harrison for management of these patients is tenapanor. The molecule again acts by inhibiting the absorption of phosphate from the GI tract. The third approach would be calcitriol, which is antagonist of PTH. You see, the problem I said was every time kidney is defective, there is a hyperparathyroidism. So the logic is that to neutralize this hyperparathyroidism, you can give a counter-regulatory hormone. And the counter-regulatory hormone of PTH happens to be calcitriol. But the disadvantage of this is again a hypercalcemia. When you continuously use calcitriol, it can cause calcium values to become higher. And the disadvantage of that is calcification of blood vessels in these patients can develop. So the problem with the molecules which are marked in yellow is hypercalcemia as a side effect. So whenever given in the exam preferred phosphate binders, your answer would be sevelamer, lanthanum and tenapanor, which are relatively having lesser amount of side effects as compared to the ones which I have discussed. Now for management of any patient of CKD, the approach that we can use is ABCDE. By ABCDE, I mean that because one of the leading causes is diabetic nephropathy, you need to keep the HbA1c of the patient less than 7%. And what better way to do it than use of insulin? When you will give insulin, the problem is that insulin is also excreted by the kidney. If you are gonna use insulin in a normal person, a person who's having a normal kidney function versus a guy with a damaged kidney, insulin will not be excreted in a guy with a damaged kidney, because of which hypoglycemia incidence would be increased. So one, you also need to adjust the insulin dosage, and this adjustment would mean that you have to give only 80% of the calculated dose. Whatever insulin that you have calculated on the basis of the sliding scale, let me say, in the patient, then you need to use only 80% of that, because you want to minimize the chances of development of hypoglycemia. Discontinue metformin in the patient, especially if the eGFR of the patient is less than 30 ml per minute. Then comes the issue of blood pressure control, for which I've said initially ACE inhibitors can be used, but always watch for potassium. If you find that the GFR is becoming lesser with ACE inhibitor, discontinue immediately. If the potassium is rising in spite of caliuretics, in spite of patiromer, he says give a trial with patiromer, give a trial with the diuretics, and keep ACE inhibitors as the primary weapon. But if it's not working, then you need to switch over to calcium channel blockers and alpha blockers in the patient. And metazolone also has an important role. In fact, the major diuretic that is mentioned in all the segments where chronic kidney disease has been discussed in Harrison, metazolone is the one that is recommended over thiazide group, as compared to hydrochlorothiazide. Then cholesterol can be elevated in these patients, exerted atherosclerosis, so statins will have to be given. Because vitamin D3 is less in these patients, I need to provide vitamin D supplementation. That will help in a better bone condition of this patient. Otherwise, pathological fractures can also occur. Secondary hyperparathyroidism will weaken the bones. So there could be a secondary fracture of the ribs occurring in these patients, or maybe of the spine. So vitamin D3 supplementation is anyway required. But apart from this, additional problem that occurs in these patients is elevated phosphate. So because the phosphate values in this patient, in fact, I can add here in the P component, which is that the phosphate values of the patient will be grossly elevated. So I can be using sivalomer or lithium carbonate for these patients apart from tenapanor. And if erythropoietin is also synthesized in the kidney, so there would be anemia occurring in this patient. So I need to give iron supplementation initially, but along with iron, I will also give erythropoietin, which would be manufactured by DNA recombinant technology to these patients. Though there is a side effect of hypertension developing due to erythropoietin injections, but this erythropoietin would help me treat critically low values of hemoglobin in this patient. You see, if I use packed RBC, in these patients, if hemoglobin is low, I can use packed RBC also. But if I give packed RBC from outside, then the stimulus for release of erythropoietin will further be suppressed. You see, if hemoglobin is less, body will try to produce erythropoietin. Kidney is not being able to do it. That's okay. But if you give packed RBCs to this chap, you will reduce the further endogenous production of erythropoietin and make the patient transfusion dependent. So it is an unethical practice that some people do, that they give packed RBCs regularly to these patients, because patient will come again and again to the clinic and hospital, and therefore you can bill the patient again and again. But that would be unethical practice. We are here to learn ethical aspects. So it is A, B, C, D, E, and then P, which would be useful for management of this patient. Apart from this, the hyperkalemia component, I can say PK. The hyperkalemia component has already been talked about, but only for the sake of completion, I'll be mentioning one drug, a novel drug for management of the hyperkalemia component of the patient, that is patiromer. So just like in chronic liver disease, you are having a tough time because of complications developing. Similarly, in CKD, there are so many problems going on simultaneously that handling this patient is always a challenge. Next up is to talk about opportunistic infections that can be seen post kidney transplantation. Most of the time, if the infection is occurring in the first month after surgery, then it would either be a wound infection, Staph aureus, or it could be herpes simplex virus, not herpes zoster, herpes simplex, or candidiasis, or a UTI in a patient. But between 1 to 6 months, apart from girovasi, what they usually love to ask in the exam is with cytomegalovirus, which is an important question. One of the common opportunistic infections between 1 to 6 months is cytomegalovirus, which can cause a graft failure in the patient. Next up, I'll be describing opportunistic infections that can be seen in patients who have undergone a kidney transplantation. In the first month after surgery, usually the infection that can be seen is either a wound infection, that would be with MRSA, methicillin-resistant Staph aureus, or it would be herpes simplex, not herpes zoster, or can be oral candidiasis or a plain UTI. But between 1 to 6 months, one of the important ones that always comes is cytomegalovirus. And with respect to cytomegalovirus, most of the time, because it's going to cause a graft failure, so the doctor has done a urine microscopic examination. And when he does a urine microscopic examination, what he finds is presence of basophilic inclusion bodies. These basophilic inclusion bodies would be found both in the cytoplasm as well as in the nucleus. And because of this particular appearance, we always read about owl eye inclusions with respect to cytomegalovirus. The highlight of these inclusions is that traditionally we read about either intracytoplasmic or we read about intranuclear inclusions, but here what you can see is I have shown basophilic with blue color. I have shown both basophilic, intracytoplasmic as well as intranuclear inclusions. Cytomegalovirus is one of the common infections that can contribute to graft failure and usually occurs between 1 to 6 months. You will also notice that in this list, hepatitis B virus and hepatitis C virus are the common things, so they are unlikely to be asked. So you need to mainly focus in the early period with respect to girovasi, cytomegalovirus, listeria and legionella. When it comes to after 6 months, then the organisms which are to be remembered by you are Aspergillus and Nocardia. The fungal infection, Aspergillus is the first one to be answered. But lots of time in multiple choice questions, they are looking for what I'm gonna describe next before you. They would love to ask you regarding infection with polyoma virus. This polyoma virus would also be referred to as BK virus. So MCQ wise, most of the time, either cytomegalovirus 1 to 6 months or polyoma virus, that is BK virus, after 6 months is the one that would be asked before you. And the special histopathological finding that could be given for polyoma virus would be called as decoy cells. We're calling them decoy cells because lots of time they can be misdiagnosed as cells which are related to kidney malignancy. You see, lots of time if there's a renal cell cancer, the cancer cells could be coming in the urine. So we call them decoy cells, and these are themselves questions decoy cells would be encountered in, or owl eye inclusion in a urine sample would be suggestive of after kidney transplantation. It means that there is a graft failure due to cytomegalovirus. The data in green has to be given importance here. And overall the number one, if he says which of these is the commonest one, then cytomegalovirus is to be answered as the commonest one for opportunistic infections post kidney transplantation. This is because the patient is already on immunosuppressive therapy. And what are the drugs that we use? Then there are two which are used usually. One of them is tacrolimus and the second is mycophenolate. Along with this, steroids are also given, and we usually aim for an early steroid withdrawal to minimize the toxicity. Now look at the twist in the question that he said. He said which cancer incidence is increased in patients of kidney transplantation who are on immunosuppression. The answer would be given by you as skin cancer / lip cancer. Remember the words earlier. I was talking about opportunistic infections that can occur, but currently I said which cancer can be seen in patients who are post kidney transplantation and they are on immunosuppressive molecules. We'll be starting these patients on calcineurin inhibitors, which I have spoken about at the moment. Now in contrast, whenever a patient goes into acute kidney injury, then with acute kidney injury, serum creatinine is one of the tests. Definitely it's the functional marker, but creatinine takes time to rise. So do we have some biomarkers available that can identify renal damage early within hours? Then one that is important and should be remembered is called as KIM1, that is kidney injury molecule 1. KIM1 is expressed in the proximal convoluted tubule of the kidney, and the values of this can be found to be elevated both in the urine as well as the plasma. So in specialized laboratories, we have facility available to check for urinary KIM1 levels, urinary or plasma KIM1 levels, and they will pick up an acute kidney injury faster than serum creatinine values. Another molecule which is of interest is NGAL, that is neutrophil gelatinase associated lipocalin. When I say this long term, I mean the first time when you read about this, neutrophil gelatinase associated lipocalin, the impression is as if you're talking about some marker related to immunity. But then this is again expressed in the tubular cells of the kidney, especially the PCT, and we can go in for urine and plasma levels. That is, we will have to write urinary NGAL levels, and they are superior as compared to a plain routine KFT talking about blood urine nitrogen, urea creatinine. These are much more, I would say, reliable in early diagnosis, because after all the objective is to diagnose a case early. Lots of time you might read a short form written in MCQs. Instead of writing NGAL, he might just write the word lipocalin, or he might write the word siderocalin. Now when I was a student at your age, or I would say especially your senior batches, in the older editions of Harrison, he always used to talk about a biomarker by the name of cystatin C. In fact, he used to begin by talking about cystatin C, but in the current edition of Harrison, that is the 21st edition of Harrison, he is totally silent. He has just mentioned cystatin C, but he has not given any specific details for cystatin C. The new entry in the 21st edition of Harrison, which is a biomarker for acute kidney injury that is given, is SUPAR. Now let's look at the full form of SUPAR. Little bit of tongue twisting data here. That would be soluble urokinase plasminogen activator receptor. Let's do it again. Soluble urokinase plasminogen activator receptor. Try to remember only the short form at the moment, that is SUPAR. So you need to remember three names. KIM1, NGAL and SUPAR are novel biomarkers for acute kidney injury. Just like in MI, troponin I, troponin T help in early diagnosis. Earlier we were having CPKMB only. Now we have early diagnosis available. We can diagnose MI in the first hour with help of HFABP. I taught that in cardiovascular system, heart fatty acid binding protein can become elevated in the first hour after myocardial infarction. So we as doctors are always trying to excel ourselves on a yearly basis, and these are the three important novel biomarkers which are to be remembered by you. Lots of time in a government hospital, we do not have access to any one of these. So if I'm having, let me say, a very suspected oliguric AKI, like after diarrhea, patient is having very scanty urination, what should I do to confirm that this is an oliguric AKI? I would be giving a bolus of furosemide. You see, once the AKI diagnosis is established, we don't give bolus, then we give a drip of furosemide. We add it to the IV fluid, whatever is which is to be given to the patient, the maintenance fluid. But if I'm having a query case of oliguric AKI, I can give a IV bolus of furosemide at a dose higher than what we normally give. I mean, instead of 1 milligram per kg, 1.5. And in spite of giving this bolus of furosemide, if the urine output is less than 200 ml at 2 hours, it means that the patient is at risk for progression to acute kidney injury. This is what is usually done whenever we are dealing with a case where we suspect kidney injury has occurred. But obviously, this would be a very subjective method. I mean, the estimation of 200 ml in 2 hours. I mean, if it is 2.5 hour estimation, if it's let me say 3 hour in 200 ml, you would still be having a dicey approach, no, whether it is present, whether AKI is not present. So he says that nowadays, in a scenario of evidence-based medicine, the novel biomarkers to be answered by you is not starting with cystatin C. It is KIM1, NGAL, and SUPAR, which are to be remembered. And I would rate this as one of the important slides, especially the novel biomarkers component that I have just explained to you, over and above all the routine things that I'm saying. As far as the AKIN criteria for diagnosis of acute kidney injury are concerned, we should be having is at least a 1.5 to 2-fold increase. You just need to remember numbers here. The numbers would go like this. In stage 1, there should be at least a doubling. There should be a doubling of the value of serum creatinine. Now the problem is that lots of Indian patients and especially kidney disease patients may already be malnourished and their muscle mass will be less. Remember, I showed you an example, no? 40 kg lady, type 2 diabetes, and her serum creatinine was 1, but her eGFR was still turning out to be lesser, right? Obviously, it was a little underestimation due to the problem in the formula, but still it was lower, no? It means that the kidney has been damaged in the lady. So what I'm trying to tell you is that serum creatinine might be even normal in some patients, but if it rises by 0.3, if it rises, suppose from 1 it rises to 1.3, I'm not saying that it should double. From 1, it becomes 2, it obviously means damage is occurring. But in lots of patients who are malnourished, where the weight is less, the muscle mass is less, if the value rises from 1 to 1.3, even that is to be considered with urine output of less than 0.5 ml per normal urine output is 1 ml per kg per hour. So a normal 60 kg man will be passing about 60 ml of urine in 1 hour. Multiplied by 24 would be 1400 ml. Approximately 1500 ml is the normal urine output in a chap. Here it is half of normal. So if you have a combination of the two, it is stage 1. Then if it is gonna be much more than this, that is, in fact, this ideally should be mentioned as 1.5 to 1.9 times. Ideally. And if it is 2 to 3 times, then I'm gonna say that this is AKI in stage 2, and if it's more than 3 or absolute value of creatinine which is working out to be more than 4 milligram, then this is to be considered as suggestive of acute kidney injury in a patient. The additional aspects to be remembered are urine output of less than 0.5 ml per kg per hour for 12 hours. There's an increase now, 6 hours, now it is 12 hours. And if I say stage 3 in a patient, then it is 0.3. Remember the values here. It is 0.5, 0.5, 0.3. Values are 6, 12, and then subsequently 24. I'll repeat once again. It is 6, 12, 24. Easy to remember. 0.5, 0.5 is 0.3. And the values are increasing as 1.5 to 1.9, 2 to 3. And then any value more than 3 or absolute value of creatinine more than 4. And alone creatinine value will not decide. It is the combination. And this AKIN criteria is was mentioned after the RIFLE criteria. Earlier we used to say words like at risk, RIFLE, RIFLE. That was the older criteria that I used to teach us senior batches. Kidney at risk, injury, failure, loss of kidney function, end stage renal disease. But now instead of RIFLE, it is the AKIN, which is usually asked, or the one that is commonly used to identify a patient who can end up with acute kidney injury. Now there are 3 types of acute kidney injury: pre-renal, renal, and post-renal. In the textbook it is mentioned, in Harrison it is mentioned that the most common variety of acute kidney injury is the pre-renal variety. This is again controversy because some apps will say it is the intrinsic renal variety, but in Harrison you can check right in the first page of chapter of AKI. He has mentioned pre-renal is the commonest variety. Now, what test can be used to differentiate between pre-renal and renal is the objective in this particular case. So I'll just draw a line diagram before you to explain this, and then we'll come back to these mathematical values. Let us take this to be representation of the tubules of the kidney, and let's see what is going on with respect to the glomerulus. in the pre-renal variety and then the renal variety. In a person who's having pre-renal variety, one of the best examples that I can give for pre-renal variety can be diarrhea with severe dehydration, or a patient having gunshot injury, extensive blood loss is occurring. In these patients, because there is dehydration in the body, therefore, whatever the ultrafiltrate goes into the proximal tubule, it will obviously be lesser, but whatever ultrafiltrate will go here, the body will try to reabsorb salt as well as water, because after all there is dehydration. So by the plus I mean that body will try to reabsorb whatever is going in the tubules. And because the body will reabsorb the salt, therefore, if I check out the urinary sodium in these patients, the urinary sodium in these patients will be relatively lesser. I'm putting a down arrow just to say, because everything is getting reabsorbed to take care of the dehydration component. But let us assume somebody who is having destruction of the proximal tubule. We have SGLT2 here present, sodium glucose link transporter, which will help in absorption of salt, water, and sugar. Now, if I put a cross over this, if I say this will not work at all, because the PCT of the patient in the renal cause, like it could be AT and acute tubular necrosis, tubules are damaged due to rhabdomyolysis, or tubules are damaged because of ischemic reasons or nephrotoxins per se. Then if PCT is damaged, if SGLT2 will not work, because salt will not be reabsorbed. In the first case, that is diarrhea, salt was getting reabsorbed from the kidney. But now if the tubule is damaged, whatever will come inside, the salt is not going to be reabsorbed. So the urinary sodium of these patients will be higher as compared to what was present on the left hand side. And therefore, one of the tests that can help you differentiate between pre-renal and the renal variety is urinary sodium values. You need to remember these values anyway. Urinary sodium is given to be less than 20 versus value more than 40. The same thing can be extended. The same logic can be used to remember FeNA, that is fractional excretion of sodium. I told you sodium is going to be lesser. The word is lesser. So therefore, you can see the arrows pointing to left, the mathematical symbol for less. And on intrinsic renal disease, I said urinary sodium is going to be more higher. So therefore, the arrow is pointing to more than 1% or going up to 2%. So urinary sodium and FeNA values would help you pick up the two varieties of renal failure in a patient. Another one would be urine osmolality. You see somebody is dehydrated. In a dehydrated patient, do you expect a dilute urine or a concentrated urine? I repeat my question. If somebody is dehydrated, he has not drunk water. Forget about kidney injury. Patient has not drunk water for the whole day. You will expect the urine to be concentrated now. So in a pre-renal variety, the urine will be relatively concentrated, whereas in intrinsic renal disease, because there is going to be no reabsorption of water occurring, it would be relatively a dilute urine. So I don't expect you to remember all the mathematical values here, but you have to remember the arrows. You can see that the arrows are going towards the decreased side with respect to urinary sodium and FeNA, and the urine is concentrated, whereas for the intrinsic variety, you will notice that the arrows are going for more than. Why? Because nothing is going to be reabsorbed and it's going to be relatively a dilute urine, so therefore the osmolality would be relatively lesser. So one of the urinary sodium plays an important role in differentiating between the two values. Plus for post-renal variety, I can anyway do an ultrasound, because most of the time it's going to be either stones or it could be benign prostatic hyperplasia. BPH is one of the important causes of why a person can land up in post-renal variety of acute kidney injury. On the subsequent slide, I'm giving you some hints which would help you crack those long stem questions. If you read a question that talks about kidney failure in a patient and also tells you that the workup of the patient shows eosinophiluria, then there can be two possibilities. Either it could be allergic interstitial nephritis, and this allergic interstitial nephritis could be seen with antibiotics. It could be like maybe even methicillin contributing to it, or it could be atherobolic kidney disease. For atherobolic kidney disease, the history given to you will be that the patient underwent a angiography procedure. Like let me say this guy, he was having chest pain episode, so you advised a coronary angiography. When you do angiography in any patient, the guide wire will be going by the femoral artery retrogradely through the aorta, and then up into the ascending aorta, then into the root of aorta, and that's where the coronaries are. But when your guide wire is going up, it could be rubbing against the abdominal aorta where atherosclerotic plaque is present. Let me say this is the abdominal aorta of the patient, and there is an atherosclerotic plaque which is present, which is causing narrowing. And your guide wire is scraping. The guide wire is going up and it is scraping against this atherosclerotic plaque. So it could cause some atherosclerotic plaque fragments to break off from here and these fragments could then move downstream into the renal artery and could cause blockage of the renal artery or its branches, and that is what is called as atheroembolic kidney disease. If you read the term atheroembolic, it is atherosclerosis, which is occurring in the abdominal aorta of the patient. The patient is undergoing an intervention, that is a coronary angiography. But during the procedure, the atherosclerotic plaque was damaged due to this guide wire, and the fragments went downstream into the renal artery, causing not only a renal failure, but there could even be manifestations like even gangrene in the patient, or he could be mentioning livedo reticularis developing in the patient, because there is a shower of emboli going downstream into the blood vessels. So it could involve the skin as well, or they could be like maybe ischemia of the toes also. So there's a possibility that there might be a purple toe in the patient as well. The message is, every time you read about angiography procedure contributing to renal failure, the thought process of yours is it could be contrast nephropathy. You see, if somebody is having a pre-existing kidney disease, like somebody is having diabetic nephropathy, let me just jot it down. Suppose somebody is having diabetic nephropathy and his serum creatinine is already elevated, and in spite of this KFT being grossly deranged, you still did angiography of the patient. There was a health camp in your hospital. You said, okay, coronary angiography, only 5,000 rupees. So there was a huge rush. And this diabetic patient also came, his creatinine was elevated, but you did not check the reports, or the doctor did not check the reports. The patient underwent angiography procedure, and post angiography, there was a renal shutdown and the serum creatinine became double or triple. Here, the description that I'm giving you is of a person who's having a pre-existing renal disease. His creatinine was already elevated. It has now become double, triple. This is where I will be thinking in terms of contrast-induced nephropathy. But if you look at the scenario for atheroembolic kidney disease, if we had done, there was no KFT done in this patient before the procedure, or even if it was done, it was normal. But after the procedure, the KFT of the patient will tend to become grossly deranged. This is because of a shower of emboli which are released from the atherosclerotic plaque in the abdominal aorta, and they are carried downstream into the renal artery of the patient. The hint towards this longish question, which describes angiography procedure and then livedo reticularis or discoloration of the toes of the patient, would be based on a simple word. Eosinophiluria is a finding seen in these patients. So atheroembolic kidney disease, a long stem question can be solved by this one single word. As far as WBC casts are concerned, everybody can answer pyelonephritis and glomerulonephritis. In glomerulonephritis, if there is hematuria, then white blood cells can also come. If RBCs will come, white blood cells will also come. So glomerulonephritis, pyelonephritis is not a big deal. What you need to remember is mainly interstitial nephritis. It's mainly 2, 4, 5 which are to be remembered for WBC cast. That is interstitial nephritis, allograft rejection, and then malignant infiltration of the kidney. The subsequent information that is asked is with respect to tumor lysis syndrome. Cancer cells, once they die, what's going to happen is that the cancer cells will be loaded with energy, ATP. So when ATP will break down, it will produce phosphate, and this phosphate will chelate with calcium. I said cancer cell is loaded with energy because it shows uncontrolled mitosis. So ATP will generate phosphate when the cell will break down. The breakdown of ATP will produce phosphate. The phosphate will chelate with calcium. So in tumor lysis syndrome, you will also notice patient having low serum calcium, hypocalcemia. All cells are rich in potassium. Potassium in the body is mainly intracellular. When billions and billions of cancer cells will die, or I can say trillions and trillions of cancer cells will die, then all this intracellular potassium will come in the circulation and there would be a hyperkalemia. More importantly, all cancer cells have a bigger nucleus as compared to routine cells in the body. You read the term anaplasia. No, anaplasia means nuclear cytoplasmic ratio is more. If there is a bigger nucleus, it means more DNA, and the breakdown of DNA will produce uric acid, and this uric acid will contribute to crystals of uric acid that can cause acute tubular necrosis. The crystals can block the tubules of the kidney, and I can use the word crystalluria, or I can just say a uric acid nephropathy developing in a patient. Tumor lysis syndrome is a complication that is always seen whenever you give chemotherapy to your patients. Like this patient is a known case of Burkitt's lymphoma. What I'm teaching you is itself a question from pathological domain. The question of your exam said, which of the following is having highest chances of development of tumor lysis syndrome? Then the logic is that the tumor that has the highest turnover rate, the tumor that has the shortest doubling time. I repeat again, tumor that has a shortest doubling time. If the cancer cells are multiplying very fast, the shortest doubling time implies that there would be a lot of cancer cells, and when you give chemotherapy, all of them are gonna die simultaneously. When you kill cancer cells simultaneously, there is a burden on the kidneys in the form of a uric acid nephropathy, and therefore, one, we should ensure adequate hydration in all our patients who are undergoing chemotherapy. It's not only for Burkitt's lymphoma, even any blood cancer patient, even solid organ tumor patients, before they undergo chemotherapy, I know that person can be at risk for development of tumor lysis. So we usually start adequate hydration. I mean, if I have to start chemotherapy in any patient, I'll not start it today. What I'll do is today I'll ensure good hydration, start IV fluids, flush the kidneys, and tomorrow morning start chemotherapy in the patient. Then you will always read patient at high risk for tumor lysis, intermediate risk or low risk. So let me say important causes for or important cancers which are high risk for tumor lysis syndrome would be Burkitt's lymphoma and B-cell ALL. Intermediate would be DLBCL, which is the commonest variety of non-Hodgkin's lymphoma. The low risk would be an indolent non-Hodgkin's lymphoma. Mainly remember the high risk. Why that is important is he will give you a situation. He will talk about a child, right? He might not talk about that starry sky appearance of Burkitt's lymphoma or a lymph node biopsy. He will say a known child, a child with this jaw swelling, Burkitt's lymphoma, underwent chemotherapy. And after chemotherapy, there is a renal shutdown in the patient. What can be done to actually prevent these manifestations from occurring? So in a high risk case, what we'll do is obviously we'll flush the kidneys with IV fluids. We'll use furosemide also, but we will use raspberry case. But if it is an intermediate risk case, in an intermediate risk case, what we will do is again flush the kidneys, give IV fluids to the patient, but we shall be using allopurinol. So what I'm trying to do here is solve that controversy that should you answer for tumor lysis syndrome or raspberry case, should you answer allopurinol? The answer depends upon the situation given to you in the exam, which is usually missed. So I thought I'll just give you the reference here also. He says allopurinol is the agent of choice in intermediate risk patients. And then he also goes on to say that raspberry case is recommended for high-risk patients. So I've given you the textbook data which is describing it, guys. There's no controversy. It depends on case to case. If I have a case of Burkitt's lymphoma, child with ALL undergoing a chemo, and there is a tumor lysis syndrome, I would like to use raspberry case. Obviously, if I am asked about intermediate scenario, first is allopurinol, and then is gonna be raspberry case. In high-risk case, it is raspberry case directly. But if he says first step, then don't answer drugs right away. Drugs are obviously used. I told you that this is the best. It is the agent of choice. If he says what is to be done in the patient initially, your answer would be adequate hydration. Next up, I'll be discussing MCQ of the previous years before you. That is, a patient of CKD is presented with protracted vomiting. The ABG shows a pH of 7.40, which is normal. PCO2 normal is between 35 to 45. Here the value is 40. So again, it is normal. The bicarbonate value of the patient is 25. Normal is the range of 22 to 26 milliequivalent. So everything is normal, because of which I'm wondering to myself, traditionally in the exam, whenever he gives a ABG based question, you're supposed to pick up, what is the type of acidosis or alkalosis, respiratory or metabolic. But here everything is normal. So when I go back to the first line of the question, I can pick up what I initially skipped, that this is a case of CKD. Now, in every patient who's having a kidney parenchymal disorder, the bottom line is that there would be an inability to excrete hydrogen. And if hydrogen will not be excreted from the body, it will contribute to metabolic acidosis in the patient. And at the same time, you are also noticing that this person is having protracted vomiting. That's because of the uremia component. Urea irritates the stomach mucosa. So this person is having multiple episodes of vomiting as well. Because of this vomiting component, there will be a dehydration coming up. The dehydration will result in activation of the RAS system. And once the RAS system comes into activation, there would be a hyperaldosteronism developing in this person. And because there is more aldosterone, there will be an exaggerated urinary loss of potassium and hydrogen. The key word was, I said, urinary loss of hydrogen, which will explain the metabolic alkalosis component. So in this patient, two processes are going on simultaneously. The CKD component is trying to lower the pH, and the vomiting component is trying to raise the pH, because of which the pH of the blood of this patient is falsely or factitiously normal. First of all, ABG reports, even if they are normal, that does not mean that everything is normal. They can be factitiously normal as well if there are two processes occurring in the body of a patient which are trying to pull the pH in opposite direction. Giving me a hint here is the anion gap. Because it's given electrolytes, let me do the formality of calculating the anion gap as well. And all I need to do here is that I need to subtract from 145 the negative charges in the body, that is going to be chloride and bicarbonate. And if you look at the mathematics here, the anion gap of this patient is 20 millicoulomb, which is much higher than the traditional value of upper limit of 12 that I've explained to you. So one thing is very clear, this person is having a high anion gap. Now, one, I will try to solve this MCQ on the basis of exclusion capability. Second, I'll try to give you the mathematical logic behind this also. Option A says normal anion gap metabolic acidosis. I can rule it out because uremia per se as a condition results in high anion gap metabolic acidosis. In this particular case, option A can be ruled out because it is not normal anion gap as we calculated mathematically. Option number B says high anion gap metabolic acidosis in a person. So yeah, I will take that into consideration, assuming the fact that this may be the answer. So because I've not read the remaining options, so just put a plus mark here, but that does not mean this is the answer. C says no acid base abnormality. Well, I'm ruling that out also because I said I could pick up theoretically two processes in the body which are neutralizing each other. So it's not that there is no acid base abnormality, it is rather being presented like this. I mean, the pH is normal, it is factitiously normal, and therefore option number C can be ruled out. Now we have to consider between B versus D, high anion gap metabolic acidosis and metabolic alkalosis versus a plain high anion gap metabolic acidosis. I've demonstrated here before you theoretically that this would be the problem in the patient, a combination of the two. It is a mixed disorder. So first of all, the answer to this would be D. And then you will obviously say, sir, is there a mathematical justification for the same as well? So let's look at the mathematical justification behind it, which is technically called as delta ratio. Delta ratio is always calculated in all cases wherever you work out patient is clinically or ABG wise having a metabolic acidosis. The formula for delta ratio would be a change in the anion gap. The ratio, if you read in the textbook, would be a change in the value of the anion gap and the change in the value of bicarbonate. So let's just do that. The anion gap of the patient is 20, upper limit is 12. So I've just subtracted that. And in the denominator, I said change in the bicarbonate. The upper limit of bicarbonate is 26. In this patient, it is a value 25, let me say. So this would be a difference of approximately 1. And if I look at it, the mathematical value has turned out to be approximately 8. Now my point is that every time you calculate the delta ratio, there can be two possibilities. Possibility number 1 can be that if the delta ratio turns out to be between mathematical value of 1 to 2, it means that the person is having a pure anion gap metabolic acidosis. But if you read that the delta ratio, or if you calculate the delta ratio is more than 2, it means it is a mixed disorder. What I mean by mixed disorder is that this person would be having an anion gap metabolic acidosis, that is okay, but he is also having a concomitant metabolic alkalosis. This is an important concept, guys, which you need to know. Delta ratio, where is it used? It is used in all MCQs of metabolic acidosis to determine whether it is a pure metabolic acidosis or whether it is going to be a mixed disorder where there's a concomitant metabolic alkalosis also present in the patient. And the query in your mind would be then, sir, what about the compensation part? Well, this is a mixed disorder. We're not talking about compensation in this particular case. Otherwise, we very well know the compensation of metabolic acidosis. You just need to reverse. It is a presence of respiratory alkalosis in the patient, but for respiratory alkalosis, the patient needs to hyperventilate, whereas in our case, he has not mentioned about any hyperventilation, but he has focused on the protracted vomiting component of the patient. Whenever you read this question, there are two ways to solve it. One is the clinical way, and forget about the mathematics part, and the second is going to be calculating the delta ratio in all cases where there is either clinically or ABG wise proven. In this patient, ABG was factitially normal, so I used the clinical information here, but this is a good pickup point. Whenever you read the combination of the two, you should understand it is a mixed disorder in the patient. Was a question that was picked up directly line to line from Harrison in the acidosis alkalosis chapter. He has mentioned this in a separate table, and they picked up the values from there, including the aspect of delta ratio as well. Now let's do another one here. This question said that a patient is presented to the casualty with multiple episodes of vomiting, and the moment you read multiple episodes of vomiting, what's clicking in your mind is possible metabolic alkalosis. The workup of this patient shows hemoglobin to be less, urea to be elevated, serum creatinine is also elevated. So I am wondering, why is there an anemia? Why there is elevated KFT? I understand, this could be a CKD process in a person. Why CKD? Because kidney produces erythropoietin. So hemoglobin, if it is lesser, means erythropoietin production is lesser, and the KFT of the patient is deranged as well. Uric acid is also slightly elevated, and the biggest problem is elevated calcium. He also says on bone marrow aspiration of this patient, 60% plasma cells are found. So I know that he is talking about multiple myeloma. And in this case of multiple myeloma, he has also described some myeloma-like events. One of the myeloma-like events described in this question is hypercalcemia, that is C, then is R, renal failure and anemia. He is not mentioned about any bony lytic lesions, but at least 3 CRAB features are discussed in this question, which is called as myeloma-like event. Now he says, what will be the next line of management for this patient? Option A talks about a nephrologist opinion for dialysis. Suppose in this question, the values were being in the range of, let me say, 13 to 15 milligram percent or even higher. When do you say life-threatening hypercalcemia is values in excess of 13? Then I would have gone straight away for hemodialysis of this patient, because this guy could have landed up in possibility of systolic arrest, because the value is in a range of 12. So I still have some time. My point is, why to go in for an invasive procedure in the patient? Hemodialysis implies that you'll have to put in a double human catheter in the jugular vein and do a HT of this guy. So I am thinking, okay, if he is not at risk for systolic arrest immediately, I can still wait, which is why I have not considered dialysis immediately. He's asking you next line management. No, that means first line management. So I've decided not to do a dialysis in this patient right away. Now I'm left with lenalidomide and dexamethasone. Dexamethasone is fine because we use steroids in patients of hypercalcemia. We do have scenarios of steroid responsive hypercalcemia. Steroid responsive hypercalcemia, sarcoidosis, or in lymphoma, and even in cases of multiple myeloma, and steroids are used first line even in multiple myeloma also. So dexamethasone looks to be a promising approach, but unfortunately is present in all the 3 options which are left behind. Now the problem with lenalidomide, which is option number B, is that it can trigger worsening of the CKD of the patient. Whenever we go in for administration of lenalidomide in a patient of multiple myeloma, we always ensure that the baseline KFT of the patient is as close to normal as possible. There is always a risk of acute kidney injury occurring with lenalidomide, because of which option number B looks a little unattractive, I would say. So I've just put a minus sign in front of it to say that not a very good approach. So I'm narrowed down to the remaining 2 options. Forced diuresis basically means that you are giving furosemide. You are adding furosemide to the bottle of IV fluid, and if you cause this forced diuresis, the good thing is that you will increase the urine output of the person, and you would be able to simultaneously lower the calcium values in the body of the patient, because after all, calcium loss in the urine can also occur with help of furosemide. Simultaneously, the fluid will also cause a dilution. Now the point is, even D option is giving you IV fluids, dexamethasone. The point against is again for zoledronate. Zoledronate is again a molecule which can always pose a risk for development of kidney failure in a patient. Already in this particular patient, there is a deranged KFT, and the derangement will worsen further. I repeat once again, option number D and option number B, D and B, both are being ruled out because there is a risk for worsening of the kidney function in the patient. As a result of it, I am left with option number C as the correct answer for this question. That would be dexamethasone with forced diuresis. Now at this point of time, I also want to show you a table from Harrison where the management of hypercalcemia is usually asked in the exam. If he says what is the first line management of the person and he's not having life-threatening hypercalcemia, then the first line management of the patient is hydration with normal saline. As you can see, it will help in decreasing the absolute value of calcium in the body. Option number B says forced diuresis, where it is written normal saline plus loop diuretic. The advantage of this loop diuretic is, again, it will cause calcium loss in the urine of the patient, plus at the same time, the saline component will also cause hemodilution also. The drug of choice for management of persons who are suffering from hypercalcemia is bisphosphonates. We can be using pamidronate, we can be using zoledronate, and especially with zoledronate, the risk of kidney failure and worsening of pre-existing kidney function is present. So we always try to hit a baseline KFT or try to achieve a good perfusion of the kidneys and then decide to go in for zoledronate in a person. So agreed that the drug of choice for hypercalcemia is gonna be bisphosphonate, But in this particular case, considering a deranged KFT, I would not like to use this molecule. Other approaches which are available with me are calcitonin nasal spray, then can be phosphate, then can be hemodialysis and glucocorticoids. And where do you usually use glucocorticoids? I mean, I can use the word steroid responsive hypercalcemia. Then three standard examples of steroid responsive hypercalcemia are sarcoidosis, lymphoma, and then the third one is anyway the topic of our interest, that is multiple myeloma. In fact, for multiple myeloma topic, I would like you to go back to the drug of choice list. Dexamethasone, bortezomib are two molecules which are primarily used. Hemodialysis, he says, is useful in renal failure and can reverse life-threatening hypercalcemia. But life-threatening is only when the values are in the range of 13 to 15 milligram percent, which was not the case. Now, I got two versions of the same MCQ. Some of my students said, sir, when the question was given to us, they mentioned that the CKD patient was having hyperkalemia. Potassium was also elevated. In this case, you can see potassium is normal. CKD traditionally should be having a deranged potassium. So, some of my students said, sir, the potassium values were about 6.4 and calcium was 14. If that is the case, if I change the two values, let me add 2 points to calcium, 2 points to potassium, then the whole MCQ is literally turning on its head and the answer would be given as option number A. If I increase the calcium values of this patient by 2 points and increase the potassium value of the patient again by 2 points, then the whole MCQ will literally turn on its head. Then the answer would be given as option number A. So these are a couple of important questions which have been asked from the kidney topic in the previous years. And I've also discussed regarding the management of hyperkalemia in the patient. One important point I want to say is that whenever we are giving furosemide to any patient who's having elevated calcium values, we are not supposed to give a bolus. We are rather supposed to add it to the bottle of IV fluid. If we are going to give a bolus to the patient, then the bolus will contribute to a sudden onset diuresis, which can actually trigger a dehydration. And if I will cause a dehydration in this person, then the calcium values will tend to rise even more. Please remember, do not answer a bolus of furosemide to the patient. It should be added to the bottle of IV fluid. It should be given along with IV fluids. Like traditionally in heart failure, no, we give a bolus shot. That bolus shot can actually cause worsening of the patient and even a possible death as well. I mean, you could convert a mild to moderate hypercalcemia to that of a life-threatening hypercalcemia also. And the cutoff for life-threatening hypercalcemia, where you answer hemodialysis, is what I've explained. And then glucocorticoids are the preferred way for 3 steroid responsive hypercalcemias, which I've explained here.